Assalamu alaikum warahmatullah. Welcome to Qasim Clinical course for Pediatrics. I'm Dr. Abir Rashidi, Program Director for Pediatric Residency Program in Al-Qasim and the course coordinator. We finished 2 workshops with Dr. Khalid and Dr. Ahmed Abu Anza. Today our workshop about data interpretation with Dr. Mohammed Hussein. Dr. Mohammed Hussein, he is consultant of GI and endoscopist, American and Canadian certified, joined to MCH Buraida this year. Welcome, Dr. Mohammed.
And hopefully we can get things done today. So the first station, so you are, the following are results of cardiac cath in a 3 days old with congenital heart disease. Can anybody give it a shot and try to interpret what's going on with this child? Anyone? So I can help you a little bit. So look at the you see the PA, the pulmonary artery. You can see the saturation is 83, which is more than the or kind of almost better than the aorta. So you have the pulmonary artery 83, the aorta, which is the last one, is 82. Does that give you a hint? Anyone?
دكتور ممكن تختار ويفتح له المايك صلاح.
دكتور عبد الله. دكتور عبد الله تسمعني؟
صلاح تفتح الدكتور عبد الله؟ ايوه تمام.
أنا ولا عبد الله ثاني؟
اتفضل دكتور عبد الله.
ما أعرف صراحة.
ما تعرف. مشاري, you want to give it a try? You seem to be writing something. Mishari, quick, because otherwise we're going to be staying here forever. I'm happy to just give you the lecture, but I think it would be better to be interactive.
صلاح تفتح الدكتور مشاري؟
دكتور مشاري
سامعني يا دكتور؟
اتفضل.
I believe since the pulmonary artery is almost greater than the aortic, this gives me a hint that this might be a PPHN.
PPHN, okay. But you look at the pressure in the pulmonary artery is 24, but the aortic is 79. So the pressure is still in the aorta is more than the pulmonary artery. I think the drive home message in this slide, you look at the saturation in the right side. If the right side saturation is bigger than the left side saturation, so this is a transposition of a great artery. So this is a TGA with VSD because there is a bit of mixing as well, right?
Mm-hmm.
So diagnosis would be TGA. What would be the current treatment? The current treatment would be a switch operation with the switch operation with the VSD closure. So what is a TGA? TGA is the saturation in the aorta is usually lower than the pulmonary artery and is lower than in the other chamber of the heart. Usually management, this is a duct-dependent lesion. So you have to keep the duct open by giving a prostaglandin infusion if you got asked about management. You also say correct the metabolic acidosis, ventilation as required, give diuretics. If there is a heart failure, give inotropes if there is a blood pressure issues. And sometimes if the duct is closed, you need to do arterial septotomy, which could be done by experienced cardiologists, and sometimes it's a life-saving procedures. And eventually, the total correction can be performed at any time, preferably as early as possible by experienced cardiothoracic surgeon. Next. Slide, Thani. So that's kind of the approach to your cyanotic heart disease. So if you have cyanosis and murmur, your child is cyanotic? Yes. If you have a murmur, then think about tetralogy of Fallot. If your child is cyanosed and no murmur, think about a TGA. And you can follow the other algorithm, which is the acyanotic. That's for you to, not sure if they get the slide or no. يحصلون السلايدات ولا؟ تمام ممكن نعطيهم السلايدات تمام so they can review it, otherwise we need to keep going. Okay, next the slide. تمام. So now I need a quick volunteer by the time I finish reading this question. 15-year-old girl is referred to you with menorrhagia and anemia. She suffered from frequent bruises during a basketball game. Her mother is concerned about her excessive loss of blood during her period, which is menstrual cycle. You've done the CBC, the hemoglobin is low, the MCV is okay, white blood cell is okay, the platelets are okay, the PT is normal, the PTT is prolonged. What's your most likely diagnosis? What other 4 investigations are indicated in this case? And what is the inheritance of these conditions? Go ahead. 2 participants raise your hand. افتح لهم اللي رفعوا ايديهم افتح لهم. أصالة تفضلي دكتورة أصالة.
أهلا دكتور.
So what's your
طيب دكتور فون ويلبرند disease.
عاشت إيدك. What's your 4 investigation you need to do?
Initially, I think I should do mixing study to check if there is any factor deficiency.
Okay.
As well as
Go ahead.
ممكن نسوي المانوال platelet number والفون ويلبرند نفسه الأكتيفيتي يعني الأكتيفيتي for the von Willebrand.
Okay, so you want to do a von Willebrand factor antigen assay. You want to do the factor 8 assay. You want to do a platelets aggregation with the Ristocin assay, and also do a family study, which is kind of plot the family tree if there's any bleeding disorders. What's the mode of inheritance of von Willebrand, Dr. Asala?
هو autosomal recessive بس type 1 و 3 هو الدومينant.
Excellent, perfect. So we can say autosomal recessive, dominant, depending on the type. Okay, excellent. So next. So anybody can give me a try for this EEG. This is a sleep EEG for 9-year-old girl referred to the outpatient department with the history of generalized seizure and abnormal movement of the mouth during the seizure. So honestly, even if you don't know how to read EEG, there are a buzzword in the history can tell you the diagnosis. And the buzzword here is abnormal movement of the mouth during seizure. She had 3 attacks, all of them at night while sleeping. Okay. Dr. Asala, you seem to be on fire today. تفضلي.
So maybe this is absent seizure because there is automatism, the mouth during moving during seizure.
Yeah, but absence seizure, does it happen during sleep?
صح. No, maybe
right?
myoclonic seizure or Rolandic.
Excellent. This is a benign Rolandic epilepsy of childhood. What can you appreciate on the EEG? If you look at the EEG, you can temporal exactly. I don't have the pointers to point, but if you look, if you focus on the central temporal, the central part, which is the C and the T, you see a lot of spikes. So this is called, the other name for the Rolandic epilepsy is called central temporal spikes and waves, right? And that is a classical EEG for the Rolandic epilepsy, and usually happen during sleep. This is a most common form of epilepsy in childhood, usually found in about 15 to 20% of young patients with epilepsy. The onset usually around 3 to 13 years. About 40% of them, of a close relative, have been found to have history of febrile convulsion. So febrile convulsion history is very important, or they can have a family history of partial and generalized seizure as well, right? And the neuroimaging usually normal. So what further investigation needs to be done?
Maybe I should do electrolyte and glucose level.
So the right answer would be none. What is the
Okay.
treatment?
Treatment, nothing.
None.
Because maybe
Exactly. The treatment is none. Treatment is not required unless episode happened during the daytime. During daytime, meaning interfering with the daytime, especially the child going to school and interfering with the school, then you treat it. And if it's too frequent or there is a parental concern, that's the only three indication for treatment. If you want to choose a treatment, you usually start with the carbamazepine. If there is no response, you can do a clobazam or sodium valproic acid or lamotrigine. About 80% of the seizure respond to anticonvulsant. The prognosis is very excellent. And usually EEG normalize within a few years of the disappearance of the seizure. Next. Okay, so you have, this is a family tree of child diagnosed with Duchenne muscular dystrophy. What is the mode of inheritance? Dr. Mishari. Dr. Mishari?
Yes, doctor.
What's the mode of inheritance here? Was that?
X-linked recessive.
Can you explain to me the diagram? So what is the
Yes,
risk of being affected or carrier in this? Just explain the diagram and answer to me the second question.
Okay. So
Explain to your colleagues.
Mother is carrier.
Excellent.
And the mother is affecting the boys, so the boy will be affected, and the girl will be carrier.
Right. So the male could be affected, and the male could be a carrier because the mom is carrier, right? So
Yes.
And usually the girls, it's excellent. So usually the daughters of the affected male will be all carrier of the X-linked gene and affected by an X-linked dominant. A woman who is a carrier will have 1 in 2 affected son. A half of her daughters will be carrier if the disease is autosomal recessive, and half of the daughters will be affected if the disease is X-linked, depending. But it's usually the most common is X-linked inheritance. Next. So 14-year-old girl is admitted with the history of abdominal pain. There is a tenderness over the right upper quadrant. A splenectomy was performed at the age of 10 years. Her hemoglobin is okay, white blood cell okay, platelets okay. Blood film shows a spherocyte, anisocytosis, and Howell-Jolly body. What is the most likely cause of her abdominal pain? Now, here you need to know what's going on. What's the primary issue? Anyone? Well, nobody's raising hand. Asala, I mean, if she's raising her hand, she will take the fire. Okay, Dr. Asala.
Maybe spherocytosis with gallstone.
Excellent. And what's the next single most useful investigation?
Osmotic fragility test for the spherocytosis.
Excellent. But in this context, what is the single most useful investigation? If you're thinking about
ultrasound.
Excellent. So think in the context of abdominal pain and you think about gallstones, so the best answer would be abdominal ultrasound. If the question would be what is the next step, then you need to confirm the diagnosis, right? Okay, next. Okay. A 6-year-old boy, a 6-year-old infant present with the water diarrhea and diaper rash, and which has been present for the last 2 weeks. The boy was born by normal vaginal delivery. Weight is 3.2. The mom is concerned about failure to thrive. There are 3 uncles died early in childhood. Okay. Your platelets is okay. You can look at the hemoglobin is okay. The white blood cell is low. The neutrophil is low. The lymphocyte is low. Monocyte is low. The CD3, CD4, CD8 all low. And you've done phytohemagglutinin stimulation, which is some sort of a mitogen response, and it was no response. The rest of the immunoglobulins seems to be within normal. The calcium on the lower side, and the chest X-ray shows thymic tissue absent. What is the most likely diagnosis? Okay, Dr. Manal. Dr. Manal? I think you need to open the mic for her. دكتورة منال
أيوة.
تفضلي.
This is primary immune deficiency versus secondary.
Okay, so it's a primary. If you want to give a syndrome, what syndrome?
Syndrome.
Thymic absent thymus. Yes, I think you know that. Just say it.
Yeah.
It is. Somebody says Al-Anud, عاشت إيدك, the George syndrome.
The George, yes. The George.
What's the mode of inheritance?
Autosomal dominant.
Excellent. What's your next step? Name one supportive diagnostic investigation. So somebody said fish. Dr. Asrar fish. عاشت إيدك. Yeah. Tamam. Fish, which is a fluorescent in situ hybridization chromosomal anomalies, right? So the George syndrome, what is the George syndrome? It's a cell-mediated immune deficiency with low lymphocyte, right? You want to keep in mind if they ask you about hypocalcemia is usually due to hypoparathyroidism, which is another feature suggestive of the George, right? Clinical features, as we said, it's include hypoparathyroidism with the convulsion and tetany due to the hypocalcemia. Absence of thymus is usually associated with recurrent infection due to the impaired cell-mediated. Other feature is palatal abnormalities like cleft lip, cleft palate, feeding difficulty, conotruncal defects. That's the buzzword, conotruncal defect. Like what? Like tetralogy of Fallot, interrupted aortic arch, VSD, and vascular rings. Hearing loss and abnormal ear examination is important. They have genitourinary abnormalities like malformed kidneys, they have microcephaly, they have mental retardation, and they have psychiatric disorder like schizophrenia and bipolar disorder. And they have the T-cell immunity. And the management is usually, you support them with appropriate antibiotic treatment or whatever, and eventually the bone marrow transplant is the curative, okay? Next. So you have a boy, can draw a square and mimic a bridge with the cubes, okay? He can only say 20 single words and can name 3 colors. What is his age? And what further management should be required for his problem? Well, first you need to identify what's the problem for you to be able to say what is need to be done. Okay. دكتور صالح.
حياك الله دكتور.
يا هلا.
Since he draws square, it's from 3 to 4 years, and but
4 years. 4 years.
But 20 single words, maybe he has a speech delay.
Excellent. So what do you need to do? What is the answer?
Hearing assessment?
Yes, hearing assessment. And number 2?
Maybe total developmental assessment.
you need to have a speech and language therapy referral, right?
Yes. Yes.
That's very important, okay? So you need to know your developmental milestone. You need to know, there is a lot of things I cannot go. Okay, next. So you basically need to know your developmental milestone, okay? Okay, so you have this EG of 4-year-old child presented with the DKA and was treated with IV insulin and normal saline. Blood taken 18 hours after treatment. Sodium is okay. pH is still slightly acidotic, well, normal. Potassium is low. ESR normal, chest X-ray normal, LFT is clotting normal. What is the abnormalities on the ECG? And what is the diagnosis? What do you see on the EEG?
Big T wave.
Where is it? Peak T wave. Where is the T wave? Okay, no. Can you show me the slide? No. افتح لي خلي أشوف. You said peak T wave. Are those T wave or QRS?
No, it's a QRS.
Exactly. You are looking. Don't be. Okay, so you thought. Okay, you said DKA. This is some sort of to do with the electrolyte. I'm gonna put peak T wave. This is a QRS. So what's the anomaly? Somebody said a U wave.
U wave.
Okay, what else? So you can appreciate ST segments depression. You can appreciate quickly if you do the segments, the QT interval prolonged, and you can see depressed T wave or slightly kind of flattened or U wave, the other name for it. What's the cause? I see somebody said, Dr. Muhammad Al-Amir. Okay, so this is a scenario. Somebody? Okay, somebody said hypokalemia. Okay, perfect. Next. So you need actually go back. ارجع للسلايد السابق. Okay, so you need to know that this is the manifestation of hypokalemia is the ST depression, prolonged QT, and depressed T wave or U wave. And the opposite, you need to know the hyperkalemia, which is peak T wave, prolonged PR interval, widened QRS interval, complex, and flattened or absent P wave. So you need to know this stuff, okay? You need to be able to calculate the QT interval and also calculate the corrected QT interval. That is very important, okay? Okay. There is manifestation, you need to be comfortable with the manifestation of hypercalcemia, like a QT interval shortening is very common, or the hypocalcemia or hypomagnesemia, which is prolonged the corrected QT interval and lengthening of the ST segment. And so these are the electrolyte manifestation. Hypernatremia and hyponatremia usually has no ECG manifestation. So get comfortable with the hypokalemia, hypo and hypercalcemia, hypo and hypermagnesemia ECG changes, okay? Next. Okay, 14-year-old girl known to have type 1 diabetes over the last 9 years, has urine test showed albumin of 30. She is on a twice daily insulin, okay? Sodium is okay, hemoglobin A1C high, potassium okay, urea, creatinine okay, and LFT and clotting normal. What's the most likely diagnosis? Okay, Dr. Muhammad Al-Amir. هلا حبيبي تفضل.
This is microalbuminuria.
Excellent. What is the next step?
Maybe we'll go for evaluating damage to the kidney.
I cannot hear you. What's that?
If there's any damage for the kidney itself.
Right. So I think the next, if they push you, what is the next step in diagnosis? The question would be, the answer would be renal biopsy. If they ask you what is the next step in management, I would say renal referral, like a renal nephrology consultation. You need to be aware of aware of complication of type 1 diabetes. Usually we start screening for them, usually after 5 years from the time of diagnosis. It's different from type 2 diabetes. We usually start screening for them at the onset of the diagnosis. Yeah. So you need to be aware of the screening guidelines for visual impairments, renal failure, stroke, blindness, myocardial infarctions, and so on. Okay. Somebody said early morning sample. Yeah, sure. So I think the reason for that is you want to make sure if this is a orthostatic. Now, for the early morning sample, if you had a protein, not albumin, this is albuminuria, okay? So this is microalbuminuria, which is very common scenario with the diabetic nephropathy, type 1 diabetes or type 2 diabetes. So I think the next step would be renal biopsy and ask your nephrology colleague, okay? Next. Now you have 14-year-old, 18-month-old baby present with vomiting, failure to thrive, and excessive drinking. Okay, the urine, the pH seems to be on the acidic side. He has a lot of glucose, amino acid, and proteinuria in the urine. Sodium seems to be okay. Bicarb acidotic. Okay. And potassium is low, phosphate is low, abdominal X-ray shows nephrocalcinosis. What is the likely diagnosis? Okay. Dr. صالح.
هلا دكتور.
تفضل دكتور.
This is renal tuberous acidosis.
So if you want to pick, if you want to, which one?
Type 2.
Type 2. What is type 2? Talk to me, distal or proximal?
It's proximal.
Why it's proximal?
Because there is a glucoseuria, amino aciduria.
Right. So when you have a proximal, you are dumping your glucose and amino acid and protein and phosphate and all the others in the urine, right?
Yes.
The proximal is the issue is with what? With not being able to reabsorb bicarb, correct?
Yes, but if there is a Fanconi syndrome, it will have all of these.
Right, right. So you will dump your bicarb. So you should have what? You should have, so that's Fanconi syndrome, right? You should have a alkaline urine, but this is a acidic urine. And also Fanconi, you don't see nephrocalcinosis. Nephrocalcinosis, usually you see it with the distal RTA. So what's going on? So this is a mixed picture of Fanconi. So I think the diagnosis will be Fanconi syndrome. The underlying issue is distal RTA, could be distal RTA, could be a primary hyperparathyroidism, could be medullary primary like hypoaldo, or could be medullary sponge kidney. So this is the, when you have nephrocalcinosis, usually this is a distal RTA. But when you have a glucoseuria and amino acid proteinuria, this is Fanconi. So this is a challenging case of mixed both Fanconi and distal. So the primary diagnosis is Fanconi. The underlying issue is mixed distal and proximal, right? If you get asked why the distal usually have nephrocalcinosis, because in the distal RTA, The inability of the distal tubule to acidify the urine lead to persistently high urine pH, which is in this case, which that will promote calcium phosphate stone formation and deposition of calcium in the renal parenchyma. Okay?
Okay.
Next. So another EEG. Now, honestly, again, look at the stem. Even if you don't read EEG, sometimes there is buzzword. 4-year-old girl present with episode of daydreaming. Now, the challenge, if you don't give you any stem, they don't give you any history, they just say, read this EEG. That would be a challenge. Okay, Dr. Umar, you want to tell us why it's absence? Dr. Umar قال absence seizure.
Because I can see in the EEG there is 3 spikes.
There's what?
3 hertz. 3 hertz.
Excellent. So when you see those vertical lines, between 2 vertical lines is what? This is 1 second. And what do you see in each second? You see 3 spike and followed by a slow wave. Okay, so 3 spike and waves. So 3 hertz, spike and waves, right? 3.5. تقريبا 3.5 إذا تحسبهم. And it's diffused. It's all the brain. So diffuse, 3.5, spikes and waves. This is absence seizure. Okay. What would be your next step in treatment?
Ethosuximide.
Excellent. If you don't have ethosuximide in your pharmacy, what is your next step?
Maybe valboric acid, valborate.
Excellent. Excellent. Perfect. Next. Okay. So that's a bit of challenges. We need to spend some time in this. This is a 4-month-old baby present with the crying during feed. What's going on here? What is this anyway? Have you guys seen that before? That was on our Canadian exam for pediatric, not gastrology, for pediatric. Okay. So this is a pH study, Dr. Asmar Hijazi. You want to tell us more about it? You want to give Dr. Asmar? Asmar, Asmar Hijazi, yeah.
Yes, doctor, I did not see this study before, but I assume that it's pH study. I'm not sure the study exactly.
Right. So look at the, okay. Somebody said pH problem. Okay. So when you look at the pH, so this is a 24-hour. So the diagnosis, before we jump into diagnosis, let's analyze the data. This is a 24-hour pH monitoring of 4-month-old baby having history of crying during feed. There's several points. You can see high numbers of reflux episode. The numbers of, if you appreciate the numbers, the second column, it says number of reflux is about 364 reflux episode, right? That's That's a significant number. Both of them about upright, usually 190. If you look at the upright, it says 190. You see that number?
Yeah.
In the supine, you see 179, correct? What does that indicate?
Correct.
Indicate a frequent episode of gastroreflux. Now, also, you can appreciate the second point. You can say this is a prolonged reflux episode because there are 15 long reflux episodes lasting more than 5 minutes. Okay, so you can see the number of longer prolonged lasting more than 15 minutes was number 15, right? With the longest reflux lasting more than 15 minutes. You see that? The longest,
yeah,
more than 15 minutes. Okay, and most of these prolonged episodes happen in the, you can see, mostly 12 of them is in the supine position, correct?
Mm.
Right. Now, if you look at the other data, which is very important, the time of the pH less than, which is 1, 2, 3, 4, 5. I think the fourth arrow from the top, which says time of the pH less than 4. The total time the pH remained below 4 is 238 minutes, with the fractionation time of the total 24 hours about 16% of the 24 hour. That is elevated. Usually the pH less than 4, the duration has to be less than 10%. But so the number here says the fractionated time says 16%, 16.5. So that's abnormal. He's spending a lot of time being less than 4. So interpretation, this is a significant gastroesophageal reflux. So this is definitely gastroesophageal reflux disease. So the next step would be you need to cover, basically the guideline says you start with the
and with the semi-upright position while feeding.
Right, excellent, excellent. So the new guidelines are from the NASPGHAN. It says if the mom is exclusively breastfed, you may try dairy-free trial for mom, dairy-free, cow's milk dairy-free, or sheep or goat, whatever. There's no difference between goat and sheep. They all have the same casein, right? Give them a trial, dairy-free for mom for 2 weeks. If that helps, that's good. If it doesn't help, you may try anti-reflux formula, like a thickened formula for 2 weeks. If it doesn't help, you may try elemental formula, especially if there is suspicions of cow's milk protein allergy. If it doesn't help, then go for the treatment, which is the PPI in this case. Okay, next. So get comfortable, don't get panicked. I think the next. Don't get panicked. So the next slide would be, this is audiogram of 3-year-old that sent to your clinic for a speech delay. What's going on and what's your next step in treatment? 2 participants raised their hand, okay? So let's see, we need a fresh blood. We need a new blood. Asala, we already know, no. We need Abdullah, no. Asma, no. Asala, okay. So that's just those 4 people, and the rest are what? Sleeping? Are you guys still sleeping? The rest? No? Okay, Muhammad Al-Am, okay. Asrar, no, Asrar, we have a new blood. Asrar. Dr. Asrar.
أي أهلا دكتور.
تفضلي دكتورة.
Yes, doctor. I see on the right, this is audiogram. I see the right side. There is the right side. There is a conductive hearing loss. Sorry,
right.
And in the left, there is as well. I think this is conductive as well.
Right, exactly. So that's both. So just to give you a bit of a background, the circle usually on the left side when I'm looking at the PowerPoint, the left side of my hand. The circles usually represent the hearing threshold for the right ear using air conduction, okay? So this is way below the 20th, so the normal is what? What is the normal? What's the normal? The normal range is 0 to 20 decibel, right?
Yeah.
If it's mild, usually between 20 and 40 decibel zone. And if it's moderate, between 40 to 60 decibels, severe loss is 60 to 80, and a profound loss is below the 80, more than 80 decibels, right? So this is lying between 20 and 50, right?
Yes.
So that's kind of mild crossing to the moderate conductive hearing loss, right? Now, the axes usually represent the threshold for the left ear using air conductions. The triangle represents the hearing threshold of the left ear using the bone conductions, okay? So you can see the bone conduction, which is the triangle, is within normal range. So that means it's a conductive issue. That means it's something in the middle ear, like a fusion or a glue ear, whatever it's called, right? If you have both the triangle coincide on the the circle or coincide on the axis, then that would be sensory neuronal hearing loss, right? Next. Okay, so a child present with apneic spells during night. Can somebody give it a shot? What is this? What are you looking at, and what is this data? Anyone? Yeah, Dr. Muhammad. Okay, so this is a sleep study of a child presenting to you with the apneic spells at night. Dr. Muhammad.
This is overnight pulse oximetry.
Excellent. Okay, good. So
Yeah,
somebody said this is polysomnography. This is not polysomnography because there is a lot of data is not there. So this is as Dr. Muhammad said, this is overnight oximetry. Okay, go ahead. Can you interpret the data, Muhammad?
Actually, I'm not sure.
Okay, so so you need to be comfortable. Don't get panic again. Look at the data. Look at the data. So this child presenting to you. Can you open the? Close this one. So look at the data. So you're gonna say this is a sleep study evaluating a child presenting a apneic spell during night. The analysis suggests that the monitoring duration was about 4 hours and 1 minute because it started around 21 o'clock, which is what? Okay, and then ended up around 1:30 in the morning, which is around, I think it's, if you do the time, it's about 4 hours sleep study, right? And you can see the oxygen saturation, the lowest SpO2 recorded is about 55%. You can see that on the right side. It says here the low SpO2 is 55, right? That's a significantly low. The average SpO2 is 93, which is slightly below the normal range, which is more than 95. Now you can say there are 280 episodes of where the SpO2 was below the 85, right? It's tell you right there. It's SpO2 on the first top left box. It says SpO2 value below 85 was, even if you are not a respirologist, you just look at the numbers and you can say, well, that's too much. That's too much. Below 80% was 20 minutes and 48 seconds, which indicate a significant period of hypoxemia, right? And you can see that those dips, which is the bottom graph, dips in the SpO2 was associated with the increased heart rate, where the highest heart rate is the 214. So that is a classical scenario of what? Obstructive sleep apnea. Somebody said that. So this is the diagnosis would be OSA. Thanks, Dr. Asmar. So this is obstructive sleep apnea, whether it's adenoid tonsil hypertrophy, whether it's some sort of congenital upper airway, that is obstructive sleep apnea. So the next step would be, if this is proven to be a adenoid hypertrophy, the next step would be urgent adenotonsillectomy. Of course, you're going to do assessment by pulmonology colleague and ENT colleague as well, right? كيف نتحول next. Okay, anybody? So this is a recording of a ECG of a child who was resuscitated and transferred to the PICU. What's your diagnosis? What's your diagnosis? So good for you, Asala. This is VTAC. Okay, Asala, what do we do?
It's depend if the patient have pulse or not having pulse.
So I'll tell you, this child has a pulse, but he is kind of semi altered level of consciousness. What would you do?
So after stabilizing the patient, I will give amiodarone. Then I will give him a synchronized cardioversion.
Right. If he doesn't have a pulse, what would you do?
If didn't have pulse, so I need to start CPR, as well as I will give shock defibrillation. Then I will give epinephrine.
Right. So if he has a pulse and altered level of consciousness, I would go for the cardioversion right away. I wouldn't waste my time, right? And they talk about sedating, giving some sedation for pain and whatnot. In real life, that doesn't work. Just go for the cardioversion. But what's the dose for cardioversion, Asala?
The cardioversion, I will start by 0.5 joule per kg.
Perfect. So the take-home message, children with the shock who have palpable pulse but condition is unstable should receive synchronized cardioversion, which is 0.5 joule per kilo, right? You can increase it to 1. Okay, you may try lidocaine, xylocaine, amiodarone, and whatever others, but I think you should go for the cardioversion. Don't waste your time. Next. Okay. Away from the complex stuff, just let's get some breather. Okay. 5-day-old present with vomiting lethargy and has not passed urine over the 18 hours. His mother is known to have diabetes since the age of 10 years. The baby has left renal mass. Sodium is okay, potassium okay, BUN creatinine. BUN is okay, creatinine is quite high. Hemoglobin is okay, platelets low. LFT is clotting normal. Urine shows a lot of protein and RBC. What is the most likely diagnosis? If you get that, whoever gets that, you should get a pat to yourself on the shoulder and say, yes, I'm good. Neuroblastoma, nope. Asala. Not okay, somebody says, who said that? RVT. Can you open the Bashar? Open the Bashar. Tell us more about it. Okay.
Yes, doctor. I think it's renal vein thrombosis.
Okay, where is it? Which side?
In the left.
In the left side, right. Excellent. Yes. This is a left renal vein thrombosis. Can you tell your colleague why you concluded that?
Because there's a renal mass, which is the most common renal vein thrombosis, and there's protein and RBC in the urine.
Good for you. Good for you. And there is a platelet low, which is kind of some sort of consumptive thrombocytopenia, but the clotting factors are normal. Okay. So yes, somebody says hematuria, low platelets, triad, and a mass, which is left renal thrombosis. Okay. So why happened? Usually renal vein thrombosis is very common in the neonatal period, usually can complicate sepsis or dehydration. And it may be observed in the infant of diabetic mother and may be associated with the umbilical vein catheterization, or maybe as a result of from a condition that is hypercoagulable state, like, clotting factor deficiency or SLE or thrombocytosis and whatnot. Renal failure thrombosis is rare in older kids. It's usually common in little kids. Nephrotic syndrome can lead to it as well. And okay, Renal vein thrombosis in newborn generally characterized by sudden development of abdominal mass with the other triad we talked about. So flank mass with the proteinuria, blood cell, and hematuria, and thrombocytopenia, that is a give, okay? The next step in a investigation, you would do renal ultrasound or renal venography. Either one would be helpful. Okay, next. Now, 3-year-old present with the swelling of his face and abdomen. He is passing dark urine. What is the likely diagnosis here? Anyone? Okay, Dr. Asrar, talk to me.
Yes, doctor.
Talk to me. What is that? You said nephritic. You said nephritic syndrome with IC, not nephrotic. Nephritic. Can you explain to your colleague what you mean? You got it right, by the way. What do you mean by that?
Yeah, I think this is the category of nephritic. It is, there is many disease under nephritic, but this patient goes most likely with low C3 nephritic syndrome, as he's having dark urine, RBC in urine.
Excellent. And what's the list for your low C3 nephritic syndrome? What are those?
Yeah, most likely could be post-streptococcal glomerulonephritis.
Post-streptococcal, one of them, and also
myeloproliferative.
MPG and myeloproliferative. Next.
And
lupus,
could be SLE nephritis. Yeah.
Lupus nephritis, which is SLE. Next.
Shunt nephritis.
Shunt nephritis. Good job. Give yourself a pat on the shoulder. Good for you. Excellent. Next. So what would be the best side test can be done? No, go back. So the best side test you be done, you might say, I will do a blood pressure and I will do a daily weight. Okay, good for you. Al-Anud, blood pressure and daily weight. Okay, next. Okay, a 3-year-old present with vomiting and delirium, and she is confused. She just recovered from a chicken pox, right? Alkaline phosphatase is very high, ALT is slightly high, bilirubin, albumin, hemoglobin, glucose, amylase, glucose seems to be low. Amylase is high. Okay, good. Al-Anud, talk to me. You said Rye syndrome. Excellent, good for you. Why Rye syndrome? And what is it? Okay, you want to give Al-Anud access to talk? Al-Anud. Yeah, this one, Al-Anud Sami. Dr. Al-Anud, explain to your colleague what you mean by Rye syndrome and what would be the further 2 tests would you carry out?
There is delirium and so change in the sensorium, so due to encephalopathy with high liver function, high ammonia level.
Okay, so you would, if somebody asked you, would say, well, this is a sudden change in the level of consciousness after a some sort of viral infection, usually chicken pox, and there is a liver involvement, and there's a lot of ammonia, right? And so this is a Rye syndrome. What would be your next step? 2 tests. You would say, I would do clotting screen. I would do liver biopsy as well, okay? And you need to consult your gastroenterologist. So likely this kid will end up in a fulminant hepatic failure, and you probably will need an urgent referral to higher center. Okay. You need to stop the offending. Usually the typical scenario they present to you is a child having a viral illness and taking aspirin, and under the 12 years of age, that could lead to a sudden presenting of Rye syndrome. The differential could be encephalitis, could be meningitis, could be diabetes, could be drug overdose poisoning, or even could be SIDS, sudden infant death syndrome, right? Sorry, abuse meant to say. So that's kind of the differential diagnosis, okay? Next. Okay. 7-year-old girl present with the lethargy, loss of weight, and excessive drinking. Her weight is what, 22. Can somebody give me the what's going on? Sodium is low, potassium slightly high, BU and creatinine okay-ish. Hemoglobin is, somebody said this is a DKA. Okay, Dr. Saleh. Okay, give Saleh. So, Dr. Saleh.
أهلا دكتور حياك الله.
Dr. Saleh, explain to your colleague why you think it's DKA. By the way, you're correct, but why you think it's a DKA?
Patient has lethargy, loss of weight, excessive drinking with bicarb 13 and positive ketones, positive glucose.
Excellent.
This is a DKA.
And what is your initial management?
First thing to do is to give bolus, normal saline, 10 ml per kg over 1 hour, then start insulin infusion and correct electrolytes.
Okay, so do you give insulin infusion or you give insulin subcutaneous?
No, infusion after the bolus.
Excellent. Okay. 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 So next, that's your initial management. So I think I was given this list. I think you guys have a station that comes, I believe, as similar to this. So they will ask you what's the interpretation. You already got the interpretation. The result we've given you. This is a. By the way, can you go back? ممكن ترجع? Can you calculate the anion gap here or no? Did I give you the information to calculate anion gap?
Okay. Sodium.
Yes, I've given you the information to calculate. I've given you the source, right?
Yeah. Okay. 137.
Okay.
And chloride is 80. It's almost more than 20. It's high anion gap metabolic acidosis.
Right. So that's consistent with the DKA, right?
Yes.
Excellent. So you would say this is high anion gap, metabolic acidosis, you would get 5 marks. And you would say, how would you calculate the anion gap? You already did the calculation, right?
Yes.
And can you tell your colleague how to calculate it?
Yeah, you will just put the potassium and sodium minus the chloride and bicarb.
Excellent. And what's your differential diagnosis for the...
It's calculated in mud piles.
Mud pile. Can you tell us what mud pile is?
M for methanol.
Right.
U for uremic acid, uremia.
Right.
D for DKA.
Right.
E for paracetamol. I for iron.
Right.
And L for lactic acidosis.
Right.
E for inborn error of metabolism.
Or maybe
salicylate poisoning.
Ethanol, right? And salicylic acid.
Yes.
Right. Perfect. 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 So there's and then they will ask you, what is this? If you were told that is this patient had history of polyuria, polydipsia, weight loss for the last month, what would be your diagnosis? Okay, DKA, you already got that. What's your management? You already got that. And can you give us the next slide? So that's from your exam. And when to stop infusion, when out of DKA, when to, what do you mean by out of DKA, when to start subcutaneous? Okay. So when to stop infusion, basically out of DKA when it's correcting, right? And to start when usually you're out of the acidosis, right? Refer to endocrine, how to manage if hypoglycemia happen, what complicated. Okay, so that's beyond the, I'll leave that to you guys. Okay, perfect. Next. So it looks like, based on what was sent to me just prior to this presentation, looks like this this is a heavily like a tested station. So please, guys, focus on it. Okay. Perfect. Now you have 4-year-old present to you. Just came back from India. She has tachycardia, chest pain, and mild fever. And you look at her blood work. She has hyponatremia. She has a, what else? A little bit of acidosis. Bicarb is low. High white blood cells. CRP is quite high. and urine, a lot of sodium, and maybe a little bit of ketone. What is it? What is it? خلينا نختار. ماكو أحد غيرهم بس دولة. دكتور محمد العامر رفع ايده. تمام، تفضل دكتور محمد. دكتور محمد. دكتور محمد, what's going on? دكتور محمد. أصالة.
دكتورة كان بتايفويد.
Okay, so I want you, don't give me the diagnosis. I want you to, I'm not asking about the primary pathology yet. I'm asking what's the interpretation of those biochemical findings? Why this child having low sodium, and why having low sodium in the blood and have high sodium in the urine, right? Okay, Abdullah, Abdullah said this is a syndrome of inappropriate ADH secretion. I agree with you, Dr. Abdullah. Give us more details. What does that mean? Secondary to chest infection, I agree with you. This is secondary to chest infection, right? So, but the underlying pathology, that could be a typhoid. I agree with you, especially with the coming back from India. So any chest infections, any intra-abdominal, any intracranial, that can lead to a SIDH. Also, certain drugs like NSAID, SSRI, cyclophosphamide, vincristine, carbamazepine can lead to SIDH. Now, you need to keep in mind the main diagnosis of SIDH, you need to have hyponatremia, which we have that. You have serum osmolality less than 280. I'm not sure if we have that here. No, doesn't look like we have it. And you need to have a urine sodium more than 20. I think we have that here. Sodium more than, sodium was 40. And usually the urine osm is more than the serum osm, right? So you need to keep in mind that SIDH is a water issue. It's not a salt issue, right? It's a water excretion is impaired, but the salt handling by the kidney is normal, okay? So the hyponatremia is not a true hyponatremia. It's because of the water retention, right? Okay, next. The treatment is usually find the cause and treat it, and you do a fluid restrictions up to 1/3 of the daily maintenance. That's the initial way to go for management, okay? 2-month-old baby present with vomiting, failure to thrive, diarrhea, jaundice, and large liver and cataract. What is the most likely diagnosis? You have the sodium is okay, potassium, chloride, you have a, okay, Saleh.
I think that the diagnosis is galactosemia.
Excellent. Why do you think it's galactosemia?
Because there is reducing substance and high bilirubin, failure to thrive, cataract.
Excellent, excellent. If I ask you, Saleh, since you are, you know the case, what would be the reducing substance? Is it a glucose-based or galactose-based reducing substance?
Wallahi, I am not sure.
Okay, so that would be a galactose based reducing substance. And what do you do the test to confirm the diagnosis?
Glucose 6-phosphate uridyl transferase.
Okay, so the RBC assay for GALD, which is galactose 1-phosphate uridyl transferase. Excellent, excellent. And what formula you put them on? Basically is a free from galactose and a free from Lactose, because lactose is what? Lactose is glucose and galactose.
Okay.
Can they take soy? Yes, they can take soy. In fact, children with been fed soy and has galactosemia, they may present late, okay? So they only present when they are fed a milk, like breast milk, which has galactose, or fed cow's milk, which has lactose, because lactose has a glucose and galactose, okay? Excellent. Usually the reducing substance, if it tells you reducing substance is galactose, this is a galactosemia. If it's a glucose, usually that could be Fanconi or diabetes or renal glucoseuria, not important of metabolism. This is a different thing, okay? 6-year-old boy present with jaundice, lethargy, and not feeding well. The alkaline phosphatase is 1200. Albumin is 60, ALT 200. PTT is a prolonged, Billy is high, INR is slightly prolonged, ceruloplasmin is low, and urinary copper is quite high. What's your likely diagnosis? Victoria Sala.
You, Doctor. Most likely maybe it's Wilson.
Okay, explain to your colleague, what do you mean by Wilson? What is it?
Wilson disease, it's a genetic disease that causes a copper accumulation.
What is the mode of inheritance of Wilson?
Autosomal recessive.
Excellent. And it's characterized by what?
It's characterized mainly by behavioral changes, with jaundice and lethargy.
Right. And due to what? What's the pathophysiology?
Pathophysiology, because I'm not sure صراحة, but it's copper accumulation.
Right. So it's a copper. So it's a copper deposition in the kidney, the liver, the brain, and other tissue, right? It's autosomal recessive and 13q, chromosome 13q. Usually, patient with Wilson present with the liver disease in the first decade of life. In neuropsychiatric, they talk about it usually in the 3rd decade of life. So as pediatrician, we don't see it, right? Adult will see it, right? And what would be other 2 tests to confirm the diagnosis?
I will do urinary copper 24 hours, as well as the serum copper.
You already have the urinary copper.
So I will do genetic study.
Before that, what would you do?
MRI liver.
Before that, what would you do? Just ask your ophthalmologist to look for Kaeser-Fleischer-Ring. And somebody said liver biopsy. I agree with you, Dr. Abdullah. So the next step would be 2 tests to help and confirm diagnosis. Liver biopsy, we usually do the weight for the copper in the liver biopsy, which is, I think, forgot the numbers, has more than certain cutoff, more than, I believe, 20 or something. And you do a slit lamp examination for the for the Kaeser-Fleischer-Ring. What would be the 3-step in management?
So we should, after stabilize the patient, we should give him chelating agent like penicillamine and zinc.
Okay, so you do a low copper diet and penicillamine and liver transplant. Tell them to stay from certain high copper diet, which is kind of the nuts, the peanuts, and there is a long list of diets, right? Excellent. Next.
Yes.
And somebody's ADEC. Yes, of course. Eventually, they would need ADEC, right? The fat-soluble vitamins, right? And family counseling and tests for family. That could be included in the list of management as well. Okay. Now the next case is 5-year-old baby boy present with history of nose bleeding and easy bruises. Okay. Bleeding time is 9. PTT is a prolonged. PT is a prolonged. Okay. Somebody says, okay, tell us, Dr. Najla. Dr. Najla, tell us. Dr. Najla, tell us, what do you think?
أهلا دكتور.
الله يحييك. تفضلي.
So this seems like a hemophilia case.
Okay.
B, type A.
Okay, so it's factor what?
Factor 8.
Factor 8?
Yes.
But the factor 7 is low.
No, factor 7. Sorry, factor 7. Because it's
so Abdullah says no. This is not hemophilia. What is it?
Come on.
So when you have hemophilia, you should have a what? The PTT or the PT is prolonged. But those are both of them prolonged. Yes, somebody, Asmar, Dr. Asmar. Dr. Asmar, that says factor 7 deficiency. I agree with you. This is factor 7 deficiency. An additional test you need to do, you need to test the common pathway, especially factor 9s and the you need to test the intrinsic pathway, which is the 8 and 9, 10, and 12 as well. So factor 7 deficiency is usually autosomal recessive. So you got to be careful. This is a trick question. This is factor 7 deficiency, right? And you need to know that factor 7 is vitamin K dependent, usually presentation as GI bleed. Somebody says PTT. Right. So that's the question, is factor 7 deficiency, right? And that's not in isolation. We were saying this is the most likely diagnosis, but not the only diagnosis. There's other component because you have the prolonged PTT that suggests additional factor deficiency or combined bleeding disorder. That's why you need to look at the you look at the intrinsic pathway. But it's been said that factor 7 deficiency can give you the prolonged PT and PTT as well. I'm not sure if Dr. Abu Anza is with us, kind of speak up on that. He's the most expert. Okay. Next. You can see we're going really running. We have our speedo on running and we still have 31 slides. So that's going to be a long night. 8-month-old present with the seasonal lethargy. What would be, looking at the sodium, potassium, what would be your diagnosis looking at this blood work? Anyone? You have high alkaline phosphatase, you have, okay, excellent, Dr. Sala. This is rickets. Can you tell us more? Why this rickets and what do you need to do next? And what's the treatment?
Because he's having high alkaline phosphatase, hypocalcemia with low 25 vitamin D.
Excellent, that's rickets, okay? And what would be your two further steps to help making the diagnosis? You already said vitamin D, and you already, I believe, said you would do X-ray of the wrist and the elbow, right? And your treatment would be calcium supplement, vitamin D, and referral to dietitian, okay?
Yes.
Very simple. Next. So you have 13-year-old present with a vegetarian, has been vegetarian for the last 3 years, complain of lethargy, abdominal pain, and occasional excessive period. Her hemoglobin is low. Her MCV is quite high. White blood is okay, and her platelets also low. And there's a increased segmentation of neutrophil on blood film. What would be likely diagnosis? Okay. Dr. Asrar, tell us why you think this way. Dr. Asrar said this is, okay, speak up, Dr. Asrar.
Yes, doctor. This is vitamin B12 deficiency as the patient's vegetarian and the MCV is high.
Excellent, good for you, good for you. Could it be folate deficiency as well?
Yeah, could be.
Okay, could be, excellent, could be, excellent. So that's called what? When you have the MCV is quite high, right, that is what?
Megaloblastic.
Megaloblastic, macrocytic, right? Okay, excellent. Since you know that, what other, what would be your, what would you test?
May I will check the MMA, the methylmalonic acid, and the homocysteine.
You're overthinking it. You're overthinking it. So they are telling you vegetarian. So
Yeah,
I would
vitamin
say
B4.
exactly. Just go for folate level and a vitamin B12. Okay. Don't overthink things. When you're too smart, that's where you get in trouble. Right? Being too smart gives you in trouble. Okay. Now this is megaloblastic macrocytic anemia. What if they asked you what are the causes of non-megaloblastic macrocytic anemia? You would say liver disease, severe hypothyroidism, and other blood disorder like aplastic anemia, red cell hypoplasia, myeloid leukemias, or drug-induced, like a drug that affects the DNA synthesis like azathioprine and Imuran and others, right? So there are two types of macrocytic anemia, megaloblastic and non-megaloblastic. Megaloblastic being vitamin B12 and folate. The other is the one we just said, right? 5-year-old referred to you with a history of nocturnal enuresis that has been caused concern for the last 3 months. Recently has started to suffer from daytime enuresis and fecal soiling. So daytime enuresis and fecal soiling, that's not normal. On examination, he has decreased ankle jerk and reduction of sensitivity over the saddle area are noted. Spinal X-ray is normal. There's no birthmark on the back because there's no signs of spinal dystrophism. At which level is the lesion? Listed 3 important causes. Name one single investigation of value in this case. Anyone? Nobody raised their hand. Okay, Abdullah, talk to me, Abdullah. Sir Abdullah, talk to me. It's right there. Sir Abdullah team. Sir Abdullah, where's the lesion? So when you have saddle anesthesia, saddle area, and you have fecal soiling enuresis, that must be the S3, S1, S4, right? S1 to S4. List the 3 important causes that could be spinal space occupying lesions like neuroblastoma or sarcoma, or could be spinal dystrophism, or could be trauma. Name the single investigation of value that you need to have MRI of a spine with contrast, okay? Spinal MRI and nerve conduction study are the most reliable diagnostic tests, but also thorough neurological exam is important as well. Okay, next. Okay. You have 4-month-old present with the history of failure to thrive. Liver is 4 to 5 centimeter large and has cardiomegaly. Examination reveals gallobrithum and engorged pedal veins, and investigation shows chest X-ray there's a lot of haziness and extending to both lower and upper lobes. White blood cells seem to be okay. Hemoglobin is quite low. Platelets okay. MCV is MCV is okay. Coombs negative. BU and creatinine seems to be okay. Bone marrow has reduced erythroblast. A normal blast means erythroblast. What is the diagnosis? Asala, HF. I don't know what's HF.
Maybe Dr. Heart failure.
Excellent. So the diagnosis is heart failure. What is the most likely underlying cause?
Maybe due to malnutrition or anemia.
So, so you have Coombs test negative. You have hemoglobin is quite low. You have reduced erythroblast. Anything else? And you have a failing heart. That's what you have. So that is, I agree with you. This is some sort of anemia. Now the answer here, the one with from the board, it says diamond black fan anemia. I not necessarily agree, because I don't have a lot of information to say this is diamond and black fan anemia. I did not get this is absent radii or a triphalangeal thumb or absent thumb, or this is dysmorphic features, or or this is Cathy-Olay spot in case of Fanconi anemia. So I don't have anything. So we would leave it as a. Somebody said the hint MCV. What do you mean by the hint MCV?
I mean, Doctor, diamond black fan sometimes have macrocytic anemia, and the MCV is almost high.
Yeah,
it's not that big of a hint, but most likely. Right.
If we are assuming this is diamond black fan, then would be the mode of inheritance is what? Autosomal dominant, right? Okay, next. Nine-year-old boy referred to you with intermittent history of hematuria and a progressive hearing loss. His urine investigation reveals RBC, proteinuria, and creatine clearance. What's the most likely diagnosis? Okay, let's see. Saleh, Asmar, Abdullah. Let's give a chance to Asrar. Asrar, where are you, Asrar?
Yes, Doctor.
Yes.
Yeah, I think this is most likely Albert syndrome, as he's having him.
Can you tell us what's Albert?
It is inherited disease. Most likely it is X-linked, but could be autosomal dominant or recessive. It affects the eyes, ears, and as well the kidney.
MashaAllah alayk, MashaAllah alayk. So you already answered the second question is X-linked dominant. What if this is a girl? What is the prognosis?
I don't know, but I think it's poor prognosis in boys.
Poor prognosis, I agree with you, poor prognosis in boys, and it's good prognosis in girls. Girls, they can have only hearing loss, sensory neural hearing loss. Kidneys function is preserved in girls, okay? Perfect. Next. 3-year-old boy presenting with a history of failure to thrive. There is no diarrhea or vomiting. His mother says he does get worm from time to time. She changes his nappy, which is diaper, up to 10 times per day. He wakes up crying in the middle of the night, asking for water. His sodium is quite high. His potassium is okay-ish. BU and creatinine is okay. Sodium phosphate, okay-ish. Albumin, okay-ish. Alkaline phosphatase, okay-ish. Serum osm is okay. Somebody says, okay, tell us, Dr. Saleh. You said DI. You jumped and you said DI. Tell me.
Maybe it's going with DI as patient have
Can you explain to your colleagues why DI and go through the result? Explain to
Okay, sure. Because DI usually going with hypernatremia as well as the urine osmolarity will be high. بس هنا normal, so not going with DI.
Do you know why it's normal?
I'm not sure.
Because he is waking up in the middle of the night asking for water. So when they are having access to water and hydrated, they don't need to drop. Serum osmolar will be maintained. Okay.
Okay.
Okay. So likely diagnosis, I agree with you. This is DI. What is other tests would you do? Why
So
this?
I will do water deprivation test to differentiate between DI and polysygenic polydipsia. Then after that, I will do the ACT stimulation test.
Okay, but why aren't you interested to know whether this is a central or nephrogenic?
Yeah.
Yes, somebody says a brain MRI. I agree with you. Whoever said that, Dr. Saleh, good for you. Brain MRI.
And the desmopressin response. So if the patient responds to desmopressin, this is central.
So I think if they asked you what additional tests would you do, I think it's fair to say brain CT or MRI would go for the MRI. And you will do a baseline hormonal assay like growth hormone, midnight and morning cortisol and TSH and T4. Now, if they ask you what is the diagnostic test, or what will you do investigate further, then you will do the water deprivation test. Can you tell us more on water deprivation tests?
Yeah, so we'll do the patient will not drink water. Then after that, we will measure the urine osmolarity. If this is primary, this psychogenic, the urine osmolarity will improve. But
Right.
if it's DI, it will not improve.
Okay, and DI if it's nephrogenic or the central?
Both.
Right, and then if you give desmopressin,
it will improve with the central, but the nephrogenic will not improve.
good for you. Good for you. Excellent. Okay, a 10-year-old present with the UTI and abdominal pain. She is known to suffer from myopia. So she has myopia. She has been tested in the past and her blood has shown high level of methionine. Skin biopsy shows fibroblast culture showing cystathione beta synthetase deficiency. Sister died at 25 years of age with the clotting disorder. Protein is positive, slightly positive in urine dipstick and white blood cell leukocyte, and organism is negative. What is most likely diagnosis? Anyone? Okay, Saleh, tell us more.
Assalamu alaikum.
Salatullah, Habib.
Since the level of methionine high, cystathionine high, deficiency, sorry.
Right.
And she has some sort of myopia and positive family history. This is most likely homocystinuria.
Right. And what other tests would you do to aid in the diagnosis? Very simple. You would do cyanide nitroprusside test. Cyanide nitroprusside test, which is a test usually looking for any sulfur-containing amino acid. In this case, is homocysteine. When you do the test, it will turn the urine test into a red-purple color, indicating there is homocysteine. List the other features or signs of this underlying condition. You would say usually cardiovascular.
Tall stature, cardiovascular, and also myopia.
Myopia.
Posterior subluxation of the lentis.
Excellent. Is it downward or upward?
Downward.
And what's upward?
Marfan.
Excellent. And do they have normal IQ or retarded?
No, decreased IQ.
Okay, so so the system are eye, CNS, and cardiovascular, right?
Yes.
Excellent. So that's kind of walking you through homocysteine and Marfan. You need to keep in your mind. I think here, what are they? Just want to show you something. I think you already said that. Oh, the heart is usually none in homocystinuria. It's the Marfan usually have the heart issues, aortic valve regurgitations, and the mitral valve prolapse. Okay. So I misspoke. So it's the eye and the CNS. Okay. 2-year-old baby preterm presented with the persistent bilious vomiting, 16-hour post-delivery. His birth weight is 2.4. His weight had fallen further down to 2 kilo. Investigation revealed this sodium is low. Okay. Dr. Saleh, tell us.
Yes, doctor. So most likely the patient have hypokalemic, hyponatremic metabolic alkalosis. With this bilious vomiting, more going with biliary atresia as well, the age going with it.
Biliary atresia, you mean?
Yes.
Or pyloric stenosis, you mean?
Sorry, pyloric stenosis, but it's bile stain, so it's
So
really
exactly. So it's bilious.
So biliary atresia going more with the bilious vomiting.
But why this child having a low sodium and so there is a alkalosis. I agree with you. There is hypokalemic, hyponatremic, metabolic alkalosis.
Maybe the alkalosis, the vomiting.
Right. The urine sodium is okay, but the urine potassium is high. So what is that? So this is a simple pre-renal azotemia, right? Pre-renal azotemia is secondary to the some sort of volvulus, some sort of intestinal obstruction, right? So you would say list the 3 abnormalities. We already talked about the sodium, the low sodium, low plasma, potassium, and high urine potassium, and high urine plasma urea ratio, right? Because you look at the urea, the BUN in the plasma is 26, and the urine is 280. That means the kidney is working well. That means this is a pre-renal azotemia, right? So that's a secondary to dehydration, secondary to, so they can get you in all these kind of scenarios. So basically, this is a pre-renal azotemia due to some sort of dehydration, secondary to the bilious vomiting, secondary to God knows whether this is intestinal obstructions or malrotation, likely malrotation, especially with the bilious vomiting in this 2H preemie. Or God knows, could be neck, right? Okay, we talked about that. Okay. 22-month-old baby present with the history of progressive loss of vision. Her initially seen GP, 17 months of concern that was not able to follow object. Give me 1 second. His mother was reassured that time and was admitted further for investigation 3 weeks later. CT, okay, excellent. Talk to me, Asala. Asala said craniopharyngioma. Teach us. Tell us what's going on.
Most likely because there is classification in the suprasellar lesion. So
Right.
this usually going with the craniopharyngioma, as well the patient have loss of vision that affect bitemporal hemianopia.
Right. Okay. So what are the, so you already got the craniopharyngioma. The question is, I'm not asking you what's the second question is the diagnosis. The first question is what other clinical tests are indicated?
I need to do electrolyte to rule out DI, as
Right.
well as do other hormone like growth hormone, cortisol level to see, most likely will be affected, all will be low.
So the question is, you got to be careful, Dr. Asala. The question is other clinical test. Clinical test. It's not investigation. It's a clinical test.
So maybe examine test urine dipstick. I will examine.
Urine dipstick is a lab test. It's not a clinical test. So somebody says visual. I agree with you. Visual field and acuity. That's Dr. Al-Anud. Shukran. And also I need to do a blood pressure and fundus examination. Okay. The second question is the craniopharyngioma. And the third question, then you can tell us about your cup. Go ahead.
Yes, so the investigation, as I said already, I will do the electrolyte mainly for the sodium. Maybe it will cause DI with this craniopharyngioma.
Excellent.
As well as I will do the other hormone, growth hormone, cortisol,
Excellent.
because maybe it will cause panhypothyroidism.
Excellent. Okay, so list the 3. Usually you said urea, creatinine, glucose, osmolality of the urine plasma, random plasma glucose, growth hormone, LHRH and TSH, and the last one is the brain MRI. Okay. Now, what's the management for craniopharyngioma?
Maybe most likely surgical treatment after
Right.
stabilization.
Subtotal resection followed by radiotherapy is usually the approach for treatment. Excellent. Excellent. Okay. 6-year-old present with purpura. She has occipital lymph nodes and left cervical lymph. Examination of her limbs reveals absent right thumb. Absent right thumb. She suffers mild mental retardation. What's going on? Anyone? Any taker? Okay, Salah, talk to me. Dr. Salah, mashallah عليك.
أهلين دكتور حياك الله.
Mashallah عليك.
Since there is purpura with absent thumb, with the decreased mental intellectuality, this is most likely Fanconi anemia.
Excellent. Tell us what's Fanconi anemia.
It's a syndrome, skeletal with bone marrow failure.
Right. So it's inherited as?
It's an autosomal recessive.
Recessive. Could be
Recessive,
some sort,
yes.
sometimes X-linked. Okay. Excellent. They are at risk of what type of cancer?
Leukemia.
Leukemia. Honestly, all kind of cancer, and they're at risk of radiation, especially AML. I agree with you, Dr. Asra. AML, and they are at risk of. We avoid radiation. And what other physical findings would you look for?
You will look for cafe-olate spots,
Excellent.
absent thumb,
Excellent.
short stature.
Excellent. 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 And what is the other investigation would you do?
Abdominal ultrasound.
Excellent. And?
For Wilms tumor and bone marrow, if you are suspecting
right. And I would do chromosomal analyses as well.
Yeah, yes.
Somebody, Dr. Muhammad Al-Amir, said chromosomal breakage study. That's, I agree with you. Looking for the, there are at least 13 gene mutation. So all of these are chromosomal breakage studies. They need to be done. And they're older patients, they have can develop other malignancy beside the AML, like GI, brain, neck, and anus malignancy. And you already said the short stature, the cafe-olate spot, and the thumb anomalies presented usually only in 40%. Male can have some sort of hypogonadism, like issue with gonads. They can have microcephaly. They can have eye abnormalities. They can have structural renal defects and also developmental delay and abnormal hearing and abnormal ear shape as well. Okay, excellent. Can you guys hear me okay though? The sound is okay, right? No? Excellent. Now let's move on. 10-year-old boy present with history of generalized pain, high fever, and aches for the last 2 days. Both liver and spleens are palpable, 3 cm. Lives near lake and been swimming in the lake. And I'm telling you, this lake has some dirty dogs, just to make your life easy. Dogs, okay, dogs. He's from the Middle East, and the following results are obtained. What is going on? Okay, his hemoglobin seems to be okay. White blood cell, he had low white blood cell. He had sodium is low, potassium is low, BUN creatinine is okay. CSF high protein. Okay, what is the diagnosis? Anyone? Anyone? No. Okay. Ala, Dr. Ala, talk to me. Hydatid cyst, you said. Dr. Asmar, it's hard. Okay. So when you have generalized, okay, I'll take that. When you have generalized pain, high fever, okay, and you have liver and spleen enlarged, if I told you this child been around just sheep giving birth, then you would, or maybe drank some unpasteurized milk, or maybe travel somewhere to India or whatever, then you'll think about brucellosis and typhoid fever. If I told you this has been having a new pet and the pet is rabbit, then you think about tularemia. If I told you this has been playing with dogs and swimming with dogs and the dogs is pooing in the swimming pools, this is leptospirosis, okay? So leptospirosis is transmitted usually to human from infected animal urines, usually whether rat or rodents or dogs swimming in the pool. Or maybe even just the rats or the rodents roaming in the house and peeing on the food. So they can have the way to diagnose is you do a stool blood culture and urine culture is called Wales test serology, right? And you treat it the same way you treat brucella and so brucella, salmonella, tularemia, leptospirosis, rickettsia, all these things, rickettsial disease, rocky spotted mountain fevers, all these things present the same. Okay? 2 days old infant has apneic attack and floppiness and needed ventilation for 17 days. Since then has been off ventilator and he has had hiccups. So the word hiccups makes you think about something, right? Don't read further. Usually hiccups can give you a hint of something. So you've done a plasma amino acid is normal apart from elevated glycerol, which is around 500. The plasma ammonia is okay. Lactate is okay. Electrolyte and urea okay. No ketonuria. CSF lactate is okay. CSF and a plasma ratio of glycerol is elevated. It's 0.3, right? So what is the likely diagnosis? Someone? Whoever gets that, that indicates you're a bookworm. Okay, Dr. Asrar, Al-Anud, you're on the right track. Talk to me.
Yes, doctor.
Asrar, Al-Anud, anyone? Okay, Dr. Asrar, talk to me.
Yes, this patient, as he's having hiccup in neonatal period, it's most likely goes with hyperglycemia. Hyperglycemia.
Glycinemia, not hyperglycemia, not a glucose, it's a glycine,
Yeah,
right?
glycine.
Excellent, excellent. So is that ketotic or non-ketotic?
This is non-ketotic.
Right, because I just told you the ketone, there is no ketone in the urine. So this is non-ketotic hyperglycinemia. Can you tell us more about it? What is that?
Unfortunately, I don't know much about it. Only that hiccup and brain needed.
Okay. So the non-ketotic hyperglycinemia is it's inborn error of metabolism caused by the deficiency in the glycine cleavage system. It's a very complex enzyme that breaks down the glycine in the body. And if you have this enzyme is missing, you have accumulation of the glycine in the blood. And more significantly in the brain. It's autosomal recessive. And the feature usually high level of glycine in the blood, high level of glycine in the CSF. And the CSF to plasma glycine ratio is usually elevated. And usually there is no ketone because the non-ketotic hyperglycemia does not involve any pathway that lead to significant ketone body accumulation. The way they present in neonatal period, they present with a severe hypotonia, lethargy, feeding difficulty, apnea, and hear me, intractable seizure. If you hear the other things beside hiccup, if you hear the word intractable seizure that is not responding to any seizure medication, think about non-ketotic hyperglycemia, NKH, non-ketotic hyperglycemia, okay? Usually when they grow up, they have developmental delay, they would have movement disorder, chorea, and that's when they get older, right? The treatment usually is unfortunately limited. You give them excellent, Dr. Manal, sodium benzoate. You give them NMDA receptor antagonist, which is the dextromethorphan, which is the cough syrup. the same to reduce the excitatory toxicity to the brain, and you do physical, occupational, and supportive, right? This is non-ketotic hyperglycemia. If they give you the same scenario, but there is ketone in the urine, then you will say this is ketotic hyperglycemia. And that is usually seen in the propionic acidemia, methylmalonic acidemia, and isovaleric acidemia, which is the organic acidemia, which is a different dog. Okay? Perfect. That's basically what we talked about. We're breaking down that. You're gonna have it for your record. Okay, what is this here? Anyone? Oh, I love that. Good job, Al-Anud. Asrar, talk to me. What is that? Okay, Hassan, Yaqub, molar tooth. Excellent. Talk to me. Hassan, we haven't heard from you. Talk to me, Hassan. Hassan Yaqub, yeah. Dr. Hassan. Dr. Hassan. Dr. Hassan, Mike, talk to me. You got it right. Talk to me. Okay, Dr. Al-Anud, Asrar, anyone?
Yes, doctor. This is a molar tooth sign. It goes with Joubert syndrome.
What is Joubert syndrome?
It's kind of neurological syndrome. They will present with hypotonia, developmental regression, I think.
Excellent. It's a genetic disorder, developmental delay, hypotonia, abnormal eye movement, distinctive breathing. It's called like the sigh breathing, right? And they have the molar tooth signs, right? And excellent. And okay, so that's Joubert syndrome. Next. And if I ask you, okay, we already talked about this molar sign. What is the diagnosis? Joubert syndrome. What is the molar sign? Why the molar sign happen? I think that's an overstretch. I think it's. I don't think they will ask you that. This is due to the signs due to the hypoplasia and aplasia in the cerebellar vermis, thickened and horizontally oriented superior cerebellar peduncle, and deepened interpendicular fossa. I wouldn't, don't worry about it. That's too much. That's kind of feels kind of neurologist board exam. How do you reach the final diagnosis? Of course, you're going to do the genetic workup. And what are the risks for GI? You need to think about GI. They are at risk of one thing, very major. It's esophageal varices. Whether it's a portal hypertension esophageal varices or normal portal circulation esophageal varices. Why? Because they are at risk of some sort of congenital anomaly between the spleen vein and the gastric vein and esophageal vein, some sort of congenital anomalies there, and they have varices there. We had a case, Joubert syndrome presented with the esophageal varices, and one of our colleagues did the ligation, and you look at the portal circulation normal, liver ultrasound is normal, so we're looking further in to see if there is any underlying some sort of intra-abdominal venous anomaly. Okay. A 4-year-old boy present with a history of developmental delay, large forehead, prominent chin, and long ears. He also has macroorchidism. What is the diagnosis? Okay, I agree with you, Sarah. This is a Fragile X. And okay, Dr. Mohammed Al-Amr. It's Fragile X. Okay. Anyone?
أهلين دكتور.
يا هلا حبيبي.
This is Fragile X syndrome.
Excellent.
What's the mode of inheritance? It's X-linked recessive.
Excellent. What are the risk of?
Yes.
What is the main developmental issue?
It's there is intellectual disability.
Right. What's if you want to choose one? Asala telling you ADHD. Would you agree with her?
Yes, they have ADHD, but the intellectual disability more.
What are the main? Okay, Manal, autism. I agree with Manal, autism. Okay, so they are mainly at risk of autism spectrum. Okay, but the others are correct as well. But if they ask you main developmental issue, then the answer would be autism. Okay, that's why you see Fragile X differential diagnosis and a Fragile X genetic testing is on every checklist of developmental delay, checklist of speech delay, checklist of autism. It's always there, okay? Newborn baby, okay, Asala, can you read the question and tell us? I'm running out of steam.
Sure, Doctor. This is newborn baby, has dysmorphic features with microcephaly, micrognathia, and down slanting for palpebral fissure, as well as he having cat-like cry. So most likely this is cry du chat, defect in chromosome 5.
What is a cry du chat?
As I know that they have developmental delay. They have crying like a cat and they having a cardiac defect. That's what I know.
Excellent. You got all of them, okay? So they have a small head, low birth weight, poor muscle tone, microcephaly, characteristic cry, which is called Kari cry syndrome. They have distinct features. They have learned when they grow up early, they are older, they get language difficulty. Majority, they have a speech delay. There's a delayed walking because of the poor muscle tone, and later in life they will have scoliosis. Okay. Death unfortunately happen in early infancy or early childhood. Okay. And where is the defect?
In chromosome 5.
5 what?
It's deletion in chromosome 5, because I'm not sure. No.
5p deletion. P as in Peter. P as in Peter. Okay. 5p. Okay.
Okay.
If you answer 5, you would get half mark. If you answer 5p, I would say 5 to get a full mark. You say 5p micro deletion. Okay.
Okay. Sure. Thank you.
Excellent. Okay. Go ahead. Next. Who's going to read that for me?
I can read.
Go ahead.
A term baby girl was born with lymphedema on the dorsum of the hands and feet. She has redundant skin on her back. This is most likely Turner syndrome.
I agree with you. Where's the defect?
It's trisomy, XO.
Okay. And if this girl happened to grow up, what is she risk at from the reproductive point of view?
She is infertile.
Infertile. Okay. Okay. Infertility. Excellent. 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 And can you tell me other cardiac features they could have? Like
yes,
what are the cardiac feature they have?
Yes, they will have the most likely they will have this is bicasp aortic valve.
Excellent. Somebody says coarctation. Somebody says coarctation, and you said, Dr. Abdullah in the note says coarctation, and you said bicuspid valve.
Yeah, so this is the most common. Bicuspid aortic valve, then the coarctation.
I agree with you, and I agree with Dr. Muhammad Al-Amir as well. It's bicuspid aortic valve is the most common, right?
Yes.
Okay. So they have coarctation of aorta. They have also bicuspid aortic valve, which is the most common. And they have high blood pressure, and they will have what kidney anomaly they have?
Horseshoe kidney, and they have normal IQ. They are intelligence.
Right. Okay. And what issue with the thyroid?
They will have hypothyroidism.
Right. And what
the risk of hypothyroidism, celiac disease also.
Excellent. Celiac and hypothyroid, and that's why they are a part of the list of the of kids. We screen them for celiac, even if they have no symptoms, right?
Yes.
Okay. And what is the gene defect? On the X chromosome, there's gene defect. It's called
Wallahi,
SHOX.
I don't know.
SHOX. Okay, it's XO. I agree with you, Al-Anud, but there is the gene defect on the X is the, so typically is 45XO, and the defect gene is the SHOX gene, SHOX, SHOX gene defect, okay? Which has a major role in the long bone growth. That's why they are short stature. They ask you whether they're short, where's the defect? Is say because they have SHOX gene defect that is responsible for long bone growth. That's why they are short. And the same SHOX gene they have associated with the GI anomaly and Hirschsprung issue. That's why they are at risk of also GI anomaly, okay? Next. A term baby was born with the ambiguous genitalia, no dysmorphic feature. A week later, present with lethargy and vomiting and is not well. And you treated for sepsis. Sodium is low, potassium is quite high. Urine is normal sodium. What is the likely diagnosis? Dr. Asrar, talk to me.
Yes, doctor. This patient most likely had congenital adrenal hyperplasia as he had ambiguous genitalia as well as light imbalance in form of hyponatremia and hyperkalemia.
So if you told me in the exam, this is congenital adrenal hyperplasia, I might give you half a mark.
Yeah.
What should you say?
21 hydroxylase deficiency, congenital adrenal hyperplasia.
I would say this is a salt-losing congenital adrenal hyperplasia, most common defect 21 hydroxylase deficiency, okay?
Yeah,
to be very thorough and very, and usually the defect is the 6p21 hydrox on the 21, 6p21, okay? If I asked you and they asked you where is the defect, and I think we already answered the defect is 6p21, 6p21. If they ask you, give me the list of the blood and urine, sorry, if they ask you if this is a girl, if this is a girl, sorry, if this is a boy, no, actually, I take it back. Who would be more at risk? The boy or the girl would be at risk of complication, and why?
I think boy, as they will not having ambiguous genitalia initially, they will present later.
Right, so they get missed because they don't have a ambiguous genitalia. They will have dark scrotum and maybe big phallus, big penis. Okay. So the blood and urine tests in boys and girls usually will show a high level of urinary 17-keto steroid. They will have normal or low urinary. So what is the? I think there is no point of going through this. What would be the hormonal assay you would send for? Would be high.
17 hydroxyprogesterone.
17. Okay, so the 17OH. Okay, perfect. I wouldn't go the rest because it's confusing. Too much information. So 17OH is the. Okay. You need to know the CAH. There are the some of them. They will have no issue with the. They will actually have the opposite, especially the 11-hydroxy. They will have the opposite. They will have hypokalemia, okay? And they will have high blood pressure, okay? Because the 11-hydroxylase pathway, it's a very strong vasopressor, okay? 18-year-old boy, not walking yet. He's not able to bear the weight, and urologic exam is entirely normal. And you look at all the testing, sodium, potassium chloride, TSH is normal, except the CK is more than 2,000. What's the diagnosis and where is the defect? Anyone? That should be very straightforward, very simple. Okay. Who's speaking? I'm sorry, Dr. Muhammad? Dr. Manal, I haven't heard from you a long time. Dr. Manal, talk to me. You're on the right track, Dr. Manal. You're right. Talk to me.
Yes, Doctor.
Yeah. What is it?
Yes.
Explain
The
to your
chin.
colleague. Explain to your colleague why you think what you thought.
Unable to walk. This
Okay.
patient. First of all, he's a boy.
Excellent.
And he's unable to walk and to weight bear his weight.
Mm-hmm.
So and his neurological examination is normal. So he's going with muscle weak and
Right.
dystrophy.
Right.
Most likely low Duchenne.
Duchenne. And where
With
is
CK high. صح.
the CK high? I agree with Asrar.
Yeah.
And where is the defect? Where's the defect? I agree, the dystrophin. Asala says dystrophin, but where is the defect? Where about? Which chromosome? It's XP21 in the dystrophin gene. Okay, I agree with you. Now, if somebody asks you, say, is it distal myopathy or a proximal myopathy? And what is the physical sign when they are sitting and they get up? How would they get up on? What is this sign called? Excellent.
Grower sign. Grower sign.
Okay, it's a proximal and is it a grower or Gower sign?
Gower sign.
Gower, it's not a grower. Gower, you got to be careful. Because if you told me grower, I will give you 0.
Yes.
So it's a Gower sign. Okay, so we say they get up on their feet, on their knees. They gradually, like an old man, old women, getting up. They يستندون على رجليهم يلا يقومون يعني because of the proximal myopathy. صحيح؟ تمام. Who's going to read that? Anyone? Asrar?
Yes, doctor. This is a 13-year-old girl present with tiredness, lethargy, and inability to move her legs. She has been well over the last few weeks, but since the beginning of the week, she has felt weak. She has never been abroad, and apart from mild cold 4 weeks ago, she is healthy young girl. Lower limb reflexes are absent. Workup show normal CBC with differential CRP albumin, immunoglobulin. Cerebrospinal fluid showed normal cell count and elevated protein, 55, which is considered elevated. Diagnosis most likely. Yeah, she's having GPS.
So what is GPS?
Guillain-Barré syndrome.
عاشت إيدك. صحيح. So that's Guillain-Barré. Guillain-Barré. The way we say it, some people say Guillain-Barré, but the way you pronounce it is Guillain-Barré syndrome. Guillain-Barré syndrome. Okay.
Okay.
So Guillain-Barré syndrome. What is the next step in workup?
Nerve conduction study and brain MRI.
Excellent. So nerve conduction studies. Okay. And what would be your next step in treatment?
IVIG.
IVIG. For how long? What's the dose?
I guess the dose is 1 gram per kg over 12 hours.
Once a day for 2 days. Okay. What is Guillain-Barré?
It is demyelination disease.
Okay, so it's acquired demyelination disease of the peripheral, characterized clinically by rapid and progressive paralysis, areflexia, variable sensory disturbance. They could have some sort of disturbance. Now, can you explain to me what is this sign called when you have normal cell in the CSF and high protein? What is this called?
Yeah, cytoalbuminic dissociation.
Excellent. Mohammed Al-Amir as well said that. Albumin. So cytoalbuminic dissociation, meaning normal cell, yet I have high protein. So that's a classical CSF finding for Guillain-Barré syndrome. Okay, and it's usually comes after some sort of respiratory illness and that. Okay, and if they ask you what they are at risk of from the respiratory point of view,
they may have respiratory failures.
Right. So yeah, so you gotta watch them like a hawk and let the PICU team aware that they might decompensate, especially if they are showing signs of respiratory distress. So you need to move them and CPAP them, or even sometimes ventilate them, right? Okay. Excellent. So do we continue or what? So 5 days old baby present, okay, we'll do. 5 days old baby present with excessive crying, feeding less, and jaundice. His first child, he is the first child to a first cousin couple. So there's a consanguinity. There are no other concerns. Normal, CBC, albumin, CRP, ALT, AST, AST negative, blood cultures, urine negative, DCT negative. Billy is, what is your diagnosis? So when you have normal albumin, normal liver enzymes, and DCT is normal, this is likely, and this is only 5 days, excessive crying, feeding less, and jaundice. That's probably physiologic jaundice. Now, I would go with the physiologic jaundice. This is, and the next step would you need to have fractionated Billy and total and direct. And the next step in treatment, this is phototherapy. So don't get bogged down and worried about it, okay? So you have 6-year-old boy present with a temperature of 38. Over the last 5 weeks, every 3 days, his temperature has gone up to 39, settle after 4 days, and then so it's a kind of every 3 days goes up and then goes down. He's been coming from Kenya, and temperature developed after the 3rd day of his arrival. No one else in the family is similar problem. Blood cultures after 48 hours, no growth. Blood film on the 3 occasion shows no parasite. There's no malaria. TB skin test more than 15 millimeter. Chest X-ray reported to be as normal. LP shows high protein cell is mostly lymphocytic, and a gram stain, no gram. The rest of the white blood cell, hemoglobin and whatnot, CRP is quite high. So that's, the question is, what's your diagnosis? So that's TB, meningitis, right? What would be the next step in management? You would say PCR for CSF for Mycobacterium tuberculosis. The treatment would be oral rifampin, INH, pyrazinamide, and ethambutol for 12 months. Just for the sake of the time, I'm just gonna run it through these stuff. 2-month-old present with the cough and not feeding well. She was full term, no previous problem. She requires 2 liters of oxygen per the nasal cannula. Episode of coughing lasting for 2 to 3 minutes, and she get apnea with those coughing episodes. So that's likely, especially when you get, where is it? Do we have the lymphocyte? Usually, I will tell you there is lymphocyte. Okay, so pertussis, I agree with you, Asala. What is the next step in workup?
We will take PCR nasopharyngeal.
Yes, so nasopharyngeal swab. And what's your treatment?
We will start macrolides azithromycin.
Right. So you would macrolide for 5 days. It depends on what type of macrolides you're going to use, erythromycin or not. You're going to be mindful for 2 months of age. When you put them on macrolide, you better be mindful of pyloric stenosis, okay? Risk of pyloric stenosis. 9-month-old to present with the history of lethargy, not feeding very well, losing weight. She was born term and has been no concerns about her the last 8 months. Hemoglobin is 10, white blood cell is elevated, neutrophil is okay, elevated, sorry. CRP is high, ALT total Billy is okay, alkaline phosphatase is okay, albumin is okay, and blood culture shows no growth, and MSU is positive. Okay, so that's a UTI, okay? And also, CSF. Okay, so that's basically looks like a traumatic CSF because no white blood cell, no organism cultures. Okay, so that's traumatic CSF. I would not buy. This is sepsis. So that's a urine UTI. What is the next step in management? So you would need to do a renal ultrasound, next step in management, and treatment would be IV third generation, I would start with, until we get the sensitivities back. So that would what would you say? 18 months old to present with a history of allergy, losing weight, and distended abdomen. There is a mass on the right side of the abdomen, okay, which is the examiner can go up and it crosses the midline. Okay, so the word crosses the midline. So if it doesn't cross the midline, it means something. Excellent. I agree with you, Asrad. Neuroblastoma, Najla, neuroblastoma, all of you. Okay, excellent. So CRP, abdominal ultrasound. So this is right abdominal mass with the calcification, no kidney tissue. Okay, so that's a neuroblastoma. Next step in diagnosis, you would say bone marrow aspiration, and what is you would do urine catecholamines, and imaging you would do abdominal MRI or CT. Okay, excellent. And eventually going to do PET scan to see the staging, because usually they end up, by the time you diagnose them, they are already metastasized. They are very aggressive. And if they ask you, they're giving you this scenario and they ask you, okay, you know it's a neuroblastoma, but they ask you, list the eye signs, manifestation of neuroblastoma. What would you say? Raccoon, excellent. Horners, excellent. What else? Dancing eye. What is this, Muhammad Al-Amir? What's dancing eyes called? Opsoclonus, excellent. Opsoclonus, dancing eyes, raccoon eye. Okay. And last one. Proptosis, okay? Oh, no, actually proptosis is mostly on the retinoblastoma, not the, okay? I take this back. 14-year-old boy present with a petechial rash, bruising very easily, and tiredness. You look at his spleen is the large, and liver is in the normal, and you look at his CBC seems to be okay. Platelets is very low. CRP is okay. The rest of the workup seems to be okay. What is the diagnosis? Somebody? Did I see that? Somebody said something? Okay, Muhammad Al-Amir. Sir Muhammad. Who? Asala? Asala, ITP, I agree with you. What else?
Mainly with isolated thrombocytopenia.
Right. If you have a petechial rash and very easily bruised, and this is a platelets, only platelets are normal. The rest of the workup is normal, and you have a large spleen. This is going with the ITP. If this is ITP, what would be the next step?
Usually with supportive management, we will give IV.
No, sorry. The next step in workup.
In workup, if this patient, the age is not typical, maybe we will do bone marrow sometimes.
Right. So what would you say? The next step in workup, I would say I would do nothing. I would just go ahead. If this is classically ITP, I would go with the treatment of IVIG. Now, there is a new classification. If you Google ITP, Canadian CPS, Canadian Pediatric Society ITP guideline, the new guideline is they classify them into minor, moderate, severe. Minor, if you have only bruises, in this case, petechial rash and easy bruising and tiredness. Even the platelets at 20, you can do conservative management. You just say, make sure there's a reliable parents, they live close to the hospital. So we don't treat numbers, we treat severity. So petechial rash, easy bruising, and the bruising is only limited in certain area, then I would do nothing, right? What? Mute. Okay. Okay, perfect. And then I would do nothing. If it's more pronounced, like, there is generalized petechiae and there's some joint, maybe a bit of epistaxis, kind of moderate, then I would do with they said they sit on the fence whether treat, not treat. If it's severe, usually like joint involvement and internal bleeding, GI bleeding, epistaxis, hematolosis and whatnot, then we'll go with the IVIG expedited. And always when you consider a steroid, you have to have some sort of bone marrow workup. 11-year-old present with the history of failure to thrive, and she is pale with no organomegaly, no lymphadenopathy. Her parents are from Pakistan and has been living in the UK for the last 15 years. Okay, so what is that? The hemoglobin is quite low, white blood cell is okay, neutrophil is okay, platelets okay, MCV is low, CRP is okay, total bili okay, alkaline phosphatase slightly high, and alkaline ALT is okay, albumin is slightly low, within normal. BO and creatinine, sodium is okay, potassium and corrected, and magnesium okay. So what's going on with this child? Okay. Who's had iron deficiency anemia? Can you speak up? You're right, iron deficiency anemia. Mohammed Al-Amir, can you speak up?
Yes, doctor.
Okay.
Okay,
Why do you think it's iron deficiency anemia?
See, the age itself, 11 months. A big factor in this age group. Patients present with failure to survive and failed. Systemic examination is unremarkable, rule out infection. And in CBC, we have low hemoglobin, low LTV, with normal electrolytes. So it could be nutritional iron deficiency.
Right, I agree with you. So that's a nutritional. The next level in workup, you would do ferritin and level, and that's about it. And treatment, iron supplement. Now it says here hemoglobin electrophoresis. I disagree with that because in Pakistan they are at risk of thalassemia. It's called Punjab thalassemia. So I disagree with that. Treat them. They don't respond. Then think about thalassemia later. So treat them first. Okay.
أنا موجودة دكتور.
يلا تفضلي دكتورة.
Okay, so we have 4 years old history with abdominal pain, pallor, jaundice, and lethargy. He's been traveling with his parents over the last 2 months in South America. The first felt unwell 2 days ago. And in the labs, he has low hemoglobin, WBC acceptable, and platelet acceptable, MCV acceptable, and CRB acceptable. He has high ALP and the albumin also.
So ALP is actually normal. ALT is normal. So the liver enzymes, I don't want you to worry about.
Okay.
I want you to focus on this. So this is a station to test your knowledge on interpreting the CBC in this context.
Okay. Regarding the blood film, he has Howell-Jolly bodies, abnormality and shaped red blood cells.
Right.
Anisocytosis with normochromic normocytic anemia. So
yeah.
What is your diagnosis? I'll go with malaria.
Okay. So the malaria, okay. Why would you go with the malaria? Wouldn't you see more high white blood cell and high CRP?
Yeah.
And there is no evidence on malaria film, so you cannot assume. And they're giving you something, holy jolly body, right? So Asrar, can you speak up, Asrar? You said something hemolytic anemia.
Yes, doctor. Hello. I think could be spherocytosis as the MCHC is high, or could be thalassemia as he's having target cell or holy jolly bodies.
Right. So I think this is hemolytic anemia, whether it's extravascular or intravascular hemolytic anemia, that's something to be decided later. So I would say the diagnosis is hemolytic anemia. I'll leave it at that. If you get a probe and ask what could be, you can say that could be extravascular hemolytic anemia, like a spherocytosis or a G6PD or sickle cell anemia, or that could be just some sort of acquired autoimmune hemolytic anemia, or MAHA, which is a microangiopathic hemolytic anemia. Now, the next question, what would you do as a workup? I would do, you would say I would do a complete blood film and probably send a 4-panel for G6PD and osmotic fragility tests along with the other workup for intravascular hemolysis workup. Okay, السلايد التالي صلاح. تمام. So الآن عندنا we have 14-year-old boy present with a chest infection and erythematous rash on his right ankle and wrist and neck. So you have child with the chest infection and a rash. Otherwise, he looks healthy, young boy. You look at his CBC, seems to be okay, except the platelets are 50, and the PTT slightly prolonged, and otherwise his liver enzymes seems to be okay. INR slightly increased, or increased actually, not slightly. So any taker for this question? Anyone? The mic are open. Go ahead and feel free to jump in. Otherwise, we'll be staying probably praying Fajr here. Chop chop.
Yes, doctor.
Yeah.
Yeah, yes, I think this patient, as he is having a platelets low with prolonged BTT, I was thinking about Von Willebrand type 2B.
Right. Okay. So Von Willebrand, that's a good thought actually. Now, what if I want to make it more clear that he had repeated chest infection?
Wiskott-Aldrich syndrome.
Excellent. So Wiskott-Aldrich syndrome. So this scenario is poorly written. It's taken from a book. So I think they should make it clear. And I agree with you. That could be Von Willebrand, right? So now they should make it clear this is a now, well, all fairness, I go back to the question. Erythematous rash, it's not a bruises, right? So it's giving you a hint. This is eczema, right? So I think with a chest infection, eczema-like rash, and a platelets of 50, that's Wiskott-Aldrich. Now, what is the next step in workup? Then you say I would do a clotting factors, probably consider thymic scan. What is the mode of inheritance? You will say this is X-linked. What is name of 3 affected system? You say the skin, eczema, immune deficiency, and the platelets. Risk for what? What is the risk for? They are at risk of leukemia, lymphoma, and risk of recurrent deep-seated infections because of their immune deficiency, right? And they are risk of recurrent bacterial and viral fungal infection because, as you know, Wiskott-Aldrich is both a humoral and cellular immunity has been affected, right? Okay, slide التالي صلاح, next slide. So you have a 6-month-old present to the pediatric emergency. You look at his face, there's extensive vesicular ulcerative lesions on the face and the upper body. You take further history, he's failing to thrive, he has recurrent infection, he has been hospitalized in the past with the severe respiratory infection. The child looks sick. He's irritable and has a high grade fever. What's any taker for this case? What do you think is the diagnosis? And giving this.
This is immune deficiency.
Right. So what is the diagnosis in this case? It's not, I'm not asking you the underlying pathology. I agree with you. Underlying pathology is a SCID. But what is what is here? So you would say this is herpes, invasive cutaneous herpes. The underlying pathology you say is SCID. I agree with you. The immediate long-term management, you need to cover appropriate with the broad spectrum antibiotic and including a cyclovir. And you would do immediate immunology consultation. Those the old days we call them the bubble babies. You have to protect them. And the long-term management, of course, somebody said BMT, bone marrow transplant. I agree with that. And what additional test needs to be performed? You need to do a full, complete blood count. You need to do a lymphocyte subset. You would see low CD3, CD4, CD8, and you also very low B cell subset and very low NK cells. And you can see a low IgG, IgM, and you will do in this case particularly not related to SCID, but this case is you need to do viral PCR for herpes, right? And what additional tests we talked about? What are the key consideration? Family education. You need to counsel them. This is a SCID. This is a life-threatening immune deficiency. We need to be careful about risk of infection and
Doctor, acquired immune deficiency like HIV.
What's that?
Maybe acquired immune deficiency.
It could be. Now, I haven't told you. Right. I mean, that's right. It could be HIV, but I haven't told you any HIV risk. Right. So, if you would say, I think to be safe, you would say, I think this is a immune deficiency. I have not given any risk factors for a secondary immune deficiency. I would assume this is a primary immune deficiency, given the child been admitted in the past and this young age. If they're giving me history, the mom has been promiscuous and sleeping with God knows with the whole city, and she has a recurrent what is it called, sexually transmitted disease, or maybe it's been incarcerated and came out of a prison, or maybe came from East Europe where HIV is more prevalent. Then I would say yes, that could be. But I agree with this. Is that's a good thought though. Slide التالي صلاح. Good. So another infant presenting with extensive crusted inflamed lesion on the cheek, shown in the image, has recurrent infection and history of petechiae and easy to bruise. What is the diagnosis? I think this is kind of repeated, but I just want to drive the home for immune deficiency. So somebody, this is Job syndrome. And what is Job syndrome? I think you want to say this is hyper IgE syndrome. No, this is not hyper IgE syndrome. Hyper IgE syndrome comes with the deep-seated infections, deep-seated abscesses, and we call them. Right. Yeah. So this is somebody. This is said which is Wiskott-Aldrich syndrome. I agree with you. This is Wiskott-Aldrich syndrome, and again, the triad is a eczema, thrombocytopenia, and immune deficiency, which is the mixed immune deficiency. Which and the thrombocytopenia is actually they have micro platelets, smaller platelets that cannot form normal clot and we lead to excessive bleeding. Also, they have recurrent pyogenic infection in the infancy. And they kind of present with the water, bloody diarrhea and petechiae in the first month of life. And there are risk of infection, mainly encapsulated or now they can have, if they ask you what other associated manifestation they might have, they have autoimmunity, they have hemolytic anemia, vasculitis, inflammatory bowel disease, and there are increased risk of malignancy, especially B-cell lymphoma and leukemia, right? So and they usually have high IgE and have high IgA, opposite to the other ataxia telangiectasia, when ataxia have low IgA and high IgM, okay? And they have a profound eosinophilia on the CBC. And when you do vaccine, they have poor response, but they have okay response to the protein vaccine, right? We can go on and on and on. And splenectomy may help to maintain platelets. Eventually, the bone marrow transplant is the cure. Okay, you need to support them until then by giving antibiotic and screening for the autoimmune condition. Slide التالي صلاح. Excellent. Any taker? I had a long day and it's been rusty voice. Any taker?
Ataxia telangiectasia.
Yeah, tell us about, tell your colleague as if you're the speaker. Explain to them what's going on.
This patient, I can read, a 5-year-old, the child present with progressive difficulty walking, clemmidness, and frequent falls. So
excellent.
The child has the history of recurrent pulmonary infections. Regarding the picture, there is in his eyes and ears, this seems to be ataxia telangiectasia because there is hypervascularization. Yani,
right. So this is telangiectasia.
Yeah.
What's your name, Doctora?
Manal.
Manal. Allah يرضى عليك. ما شاء الله عليك. Allah يوفقك إن شاء الله. I hope you're going to be a really excellent pediatrician. Thanks for the spirit of participation. Okay, excellent. So this is ataxia telangiectasia. Now the workup. Where is the problem? The problem in the ataxia, it's a mutation in the ATM gene, and you can confirm that by gene sequences. The function of the ATM gene is really unclear, but what it seems to be, they think, is detect the DNA damage. When it detects the DNA damage, it blocks the cell growth from division until the damage is repaired. And the biggest problem with the abnormal DNA repair, they can have increased sensitivity to radiation. So we say part of the counseling piece is if you ask about counseling, you say avoid ionizing radiation. What are the other physical features in ataxia? You can have ataxia, which is cerebellar. Usually early in toddler, they become clumsy, wobbly, and may be mistaken for ataxia cerebral palsy, ataxic cerebral palsy. And you can put ataxia as one of the differential diagnoses. Usually by 10 to 12 years of age, they are wheelchair bound by teenage year. The other manifestation, physical finding, is telangiectasia, usually prominent on the face and the conjunctiva and the earlobes, and usually appear not early, appears about by 4 to 5 years of age. Other features, they have a progressive neurodegeneration. They will have dysarthria, very unclear speech articulation. They will have nystagmus. They will have oculomotor apraxia, which means they are inability to follow object and will move their head to compensate while looking for an object. If you point to something, say, look at it, they cannot move their eyes. They move the entire head toward it, right? And the other feature is the immune deficiency. And as we said, this is the opposite to Wiskott Aldrich. They will have low IgA, where Wiskott Aldrich will have high IgA. Okay, and and they have a lot of sinopulmonary infections, and eventually they will have a bronchiectasis for repeated chest infection. The other trivia in the exam, you need to screen them for a alpha-fetoprotein because they are at risk of hepatoblastoma, right? And they eventually, go ahead.
Even genetic tests?
Yes, genetic tests. You need to do genetic tests to confirm for the ATM, not ATM machine though, ATM gene mutation. Okay. So slide التالي صلاح. So just I'm going to run it through this. So this is we're still in the immune deficiency though, so because I want to drive home immune deficiency message. This is a 5-year-old. This is not immune deficiency though. This is 5-year-old boy present with recurrent skin infection. He has required drainage of abscess on 2 occasions. There are no other concerns about him. You look at the CBC. What do you think about the CBC here? So he has neutrophilia. He has a okay. So Dr. Asala, talk to me.
Okay, doctor. On the CBC, he's having neutrophilia, as well as the other lab, the immunoglobulin in the normal range, not B-cell defect.
Excellent.
And
so what's going on? Just go for the chase. Go for the meat. What is it?
It's going with CDD as the patient have recurrent infection and recurrent abscess with the neutrophilia, mainly phagocytic defect.
Excellent. So this is CGD. What is CGD? Chronic granulomatous disease, right? So what is it?
It's a problem in the phagocyte. It's phagocytic defect in the killing defect.
They phagocyte the organism, the bacteria, like Haemophilus influenzae and the pneumococcus and whatnot, and the strep pneumonia, whatever, but they cannot generate the oxidative burst to kill it. So they keep engulfing and engulfing and engulfing, and you end up with a lot big abscesses. We call them the cold abscesses, right? And they get decolonized, especially with the Staph aureus in this case. So the diagnosis would be, you would say the child is colonized with the skin infection with the Staph aureus. The underlying issue is CGD. How do you diagnose? You do skin and nasal swab, and you do, for this case, swab for the staph, for MRSA, but the definitive diagnosis is you do MBT, which is nitro-blue tetrazolium test, to test for oxidative burst of the neutrophil, and hence the neutrophilia, because they cannot kill and generate the burst. They try to compensate. They mobilize a lot of neutrophil. Next. صلاح السلايد التالي. And that's the cold abscess. You can, this child having this big abscess in the axillary, and you get all this big lymph nodes filled with the abscesses. No, so the message I want to drive home is, if you are faced with the scenario of a child having recurrent infection, you suspect inborn error of immunity. Believe it or not, there is something called inborn error of immunity. It's not inborn error of metabolism. The new nomenclature is called inborn error of immunity, IEI. So if you have suspicion of recurrent infection, you say, well, is it T cell? And if it's B cell and phagocytic or complement, if it's bacterial infections or mycobacterial viruses like CMV, EBV, parainfluenza, or fungus, you think about this is likely T cell. If you get mostly bacterial, especially the encapsulated one, then you think that could be the B cell, especially if you have parasitic infection with its Giardia lamblia or intraviruses. The scenario presented with the CGD, when you have big abscesses and cold abscesses, and you get the child colonized with the Serratia marcescens or Burkholderia, similar to kind of picture of CF. You think of this as a phagocytic issues. And if you have something to do with the Neisseria meningitis, especially the complement, or with the autoimmunity, you think about the complement issues, right? السلايد التالي. But if you say صراحة هو هذا السلايد اللي تكلمنا عليه، انت ما حركت لعد؟ تمام، هو هذا اللي تكلمنا عليه. ما اعرف شفتوا السلايد الاول ولا لا؟ شو تتكلم عليه؟ تمام، هذا السلايد هذا تكلمنا عليه، هذا اللي تتكلم عليه الان. ما اعرف شفتوه ولا لا؟ تمام، لانه انا دا اباوع على الكمبيوتر وهو دا يحرك على التليفون، فاني عيني على الكمبيوتر يعني، فدا يصير لاج يعني. ممتاز، شفتوه، شكرا أصالة. السلايد التالي صلاح. عفوا، اي هو هذا السلايد. خليك خليك على هذا السلايد، ارجع لذاك السلايد السابق. السلايد السابق، هذا السلايد السابق صلاح. تمام. But if you don't have a case of recurrent infection, but you have predominantly autoimmunity, inflammatory bowel disease, and you have autoimmune vasculitis, autoimmune hemolytic anemia, whatever, you think about different pathway of the immune deficiency. You think about the autoimmune cytopenias, lymphoproliferative. You think about the immune dysregulations and the lymphoproliferative syndromes. You think about the immune dysregulation like Apex, IL-10 deficiency, or the others. So I'll leave that, especially when you have a recurrent fever, arthritis, and SLE-like picture. So you think of those. السلايد التالي صلاح. So now the slide التالي, so you need to think about the primary immune deficiency when you're faced with one or more of the following signs. If you have 4 or more ear infection within a year, 2 or more sinus infection, 2 months or more being an antibiotic with little effect. If you have 2 or more pneumonias, so 2 or more sinus, 2 or more pneumonia, 4 or more ear infections, 2 or more deep-seated infections, and including septicemia. And if the child is failing to thrive, if you have recurrent skin or organ abscesses, if you have recurrent thrush in the mouth or fungal infection, if you have needing IV antibiotic to clear any infection, you need to think of the primary immune deficiency. Also, if there's a history of primary immune deficiency and a setting of consanguinity, infantile death, and affected maternal uncles, you think about the slide التالي. And also you think السلايد التالي صلاح. You also think about the pure primary immune deficiency. You have recurrent pyogenic infections. You have illness. If you give vaccine like MMR, varicella, and the child get really sick, you say, oh, that could be immune deficiency. If you give a blood transfusion, anytime you get a blood transfusion and you have adverse reaction, you may think of the primary immune deficiency. If you get delayed wound healing, especially if with LADs, leukocyte adhesion defects, they have poor wound healing. And if you have the question they love in the exam is delayed separation of the umbilical cord, which is especially more than 3 weeks, that's likely in the LAD adhesions defect, right? And also if your kids has some sort of skeletal dysplasia, congenital heart anomalies, and dwarfism, albinism, thrombocytopenia, or being dysmorphic. السلايد التالي صلاح. And that's summarize the immune deficiency. If your child is having pneumonia, otitis media, and osteomyelitis and meningitis, think about the humoral pathway like immunoglobulins. If you have the cutaneous candidiasis, you have more opportunistic infection. You think about the T cell and so on. You can read that. I think we already covered it. السلايد التالي صلاح. Now, more questions. So we have 7 days. I have the urge to skip these questions because I have more important slides. So let's power through them. 7-month-old present with jaundice. He is pale. He's lethargic over the previous month. He has been started on solid food, and last week has started on malaria prophylaxis because he was traveling with his parents to Kenya this week. Now you check his hemoglobin is low. Right. So talk to me, Al Anud. You said G6PD. Talk to me.
Yes, okay. No.
Yeah.
There is anemia with normocytic and total bilirubin high.
Right.
With history of medication and peripheral blood film with hemolysis.
Right. And malaria prophylaxis, which are known to have a hemolysis with the G6PD, right?
Yeah.
So this slide it tells you again you need to be you need to know your CBC. You need to know how to read your CBC and get a lot of information. You need to know your hemolysis. You need to know the medication for G6PD. So the diagnosis would be G6PD would be the next setup in the step in the workup. You need to do the G6PD assay, and the inheritance is what, Al Anud?
It's an X-linked recessive.
Excellent. Good for you. Proud of you. Good. السلايد التالي. Okay. Al Anud, I'll push you further. Take this question, please.
A 10-year-old presented with the generalized edema, clubbing, and tiredness. This has been going on for the last 2 months, and he gets tired easily. His parents are from
Slovakia. He's Slovak.
And recently
he recently moved to this country, to Saudi Arabia, right?
So
you look at his hemoglobin is low, his ESR is high, and his CRP is okay. Platelets are okay. Sodium is slightly low. Bilirubin is okay. Albumin is at 12. Okay, so he has high ESR, high albumin. He has edema. He has a clubbing, and he gets easily tired. So you do sweat test is okay. You do MRI of the abdomen. There is a there's wall thickening of the small bowel. What would you most likely diagnosis? One diagnosis.
I don't know, maybe neuroblastoma? Not sure.
Oh my goodness. Okay. I have edema, I have a clubbing, I have tiredness. But good to try though. Okay. Okay. Did I get disconnected? Hello? Can you hear me?
Yes.
Okay. So Abdullah, talk to me. You said a protein loss. Protein losing enteropathy. Right. That's a protein losing enteropathy. If you want to pick one pathology that could lead to that, what would be? With the small bowel wall thickening. It's a screaming in the face. Yes, Crohn's, Asrar. This is a Crohn's. I agree with you. Differential diagnosis would be any other differential diagnosis of protein losing enteropathy, celiac, small bowel TB, blah, 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 blah. And what do you need to do next? You need to consult your GI. They probably do a celiac serology. They probably do a chest X-ray and maybe TB skin test. And finally, they need to do a GI, like endoscopy, upper or lower endoscopy, right? So hypoalbuminemia, you need to be aware of it. You need to know how to fecal calprotectin. I agree with you. You need to know about the hypoalbuminemia, whether it's a nutritional, whether it's dumping in the kidney, like nephrotic, whether it's a liver in the cirrhosis, whether it's a heart, whether a heart failure, whether it's a GIT, like inflammatory bowel disease, whether it's a lymphangiectasia, especially primary lymphangiectasia, whether it's a sarcoma or TB bowel, especially TB ileitis or amyloidosis, all these things. السلايد التالي. Right. So Asrar, you want to take that?
Sure, doctor. This is a 5-year-old baby girl present with lethargy, possible seizure, and not feeding very well. The head ultrasound showed intracerebral bleeding. The CT scan showed no subdural bleeding, but confirmed the intracerebral bleeding. MRI showed no blood vessels abnormality.
So what do you think? What's going on? Your CBC seems to be okay-ish, except the PTT is very prolonged. Right.
I noticed.
And the rest of the liver enzymes, INR is prolonged as well. The PTT prolonged, the INR prolonged. So what is that?
So it could be factor deficiency to be.
Right, that's a factor deficiency. What factor deficiency? Dependent on what? He's 5 days old.
Yeah, vitamin K.
Right, and I told you this is a breastfed baby, right?
Yep.
Right, so the mom refused the vitamin K injection. She's breastfeeding. This is hemorrhagic disease of the newborn. Diagnosis, treatment, you need to give IM vitamin K. Can you give oral? Oral is not as effective as the IM. The IV is not as effective as the IM. IM is the best. So that's the drive home message. The slide التالي. And you need to appreciate 1972, which is factor 10. 972 is the factor vitamin K dependent. Anyone taking this question quickly, please?
I'll take it.
Okay. Your name, Victoria?
Asmar.
الله يرضى عليك. تفضلي دكتورة.
A 13-year-old girl presented with pulmonary crashes, multiple bruises on her legs and forearm. She is well, with no organomegaly or large lymph nodes. Her hemoglobin is 12.7, WBC is 11, and platelets is 240, and BT is 10. Bleeding time is 10 minutes, and ABTT is 90, and INR is normal, I think. Blood film shows lymphoblast and anisocytosis.
So what is that?
With this pulmonary crashes and multiple bruises, but she has normal platelet. I would think of it's not ITB for sure. For it could be a von Willebrand disease.
I agree with you. I think it's mostly fitting with the von Willebrand, right? Your treatment would be supportive with factors. I think there is something wrong with this question. I am not entirely sure what is it, but I think there is something wrong with this question. If you give me 1 second, I will figure it out. I think there is something wrong with this question. Okay. Right. So that's so 13 per crash, a bruise. She's well, no organomegaly or lympho. Okay. Okay. So the textbook question answer says this is hinoxulum purpura. I kind of disagree. With this PTT is high, yeah, okay, well, the blood film is showing no blast and anisocytosis. Now, they could have a prolonged PTT, and PT, yes, the bleeding time is slightly elevated as well. Now, the question is, could that be, agree with them, it's hinoxulum purpura? I have trouble accepting this kind of answer. But I think your homework to say, could hinoxalum purpura have some sort of a bleeding tendency, especially if they have some sort of vasculitis and trapping, like consumptive thrombocytopenia and factor usage. I'm having trouble accepting this kind of answer. Okay, I'm not sure if one of the colleague hematology is with us, can support us with this question, but I really doubt it. So just throw this question to the garbage. السؤال التالي. "13-year-old with the abdominal pain, high temperature, and abdominal pain, high temperature, and she is vomiting. And you've done urine microscopy. You have white blood cell, no nitrate, red nitrate, but a lot of red blood cell, a lot of protein. Renal ultrasound shows multicystic kidneys. And so whether it's this diagnosis, this is a scenario trying to test you on reflux nephropathy investigation. You do indirect MAGA3, and you do, so this is a reflux nephropathy, like VUR, okay? So you need to know that. I'm not excited about this question anyway. السؤال التالي صلاح. So this is a 10-year-old. She has diarrhea and then blood in the stool, and you look at the urea is quite high, and she has anemia, and she has a. So this is a scenario of hemolytic uremic syndrome. Okay. What to monitor for urine output. The treatment is restrictive fluid. Okay, I need to be aware of the CBC finding and the lab testing of hemolytic uremic syndrome. Okay, and they have the microangiopathic hemolytic anemia, which is called MAHA. Okay, السلايد التالي صلاح. This is another nephrology. A 6-year-old present with swelling of the face scrotum. You look at his albumin is quite low. He is swollen. Urine output is high, and this is a nephrotic syndrome. Diagnosis: 24-hour urine collection for a protein, and the treatment is steroid. السؤال التالي صلاح. Okay, and you take care for this one. This one I think is interesting. Any take care?
Yes.
Yeah, go ahead, Victoria.
A boy was born at 32 weeks gestation to a mother with type 1 diabetes. He was ventilated from day 1 to day 7 and was then on NCPAP of 7 cm water pressure and 40 to 55% O2 until day of 27. He was transferred to tertiary. He was edematous for the first 7 days and had wide-spaced nipple, low CTers, short neck, dilated cardiomyopathy, and stridor. Positive genetic testing showed the presence of the PTPN11 gene. Latest results are as following: capillary blood gas, BaO2 5, CO2 8.12, pH 7.30, bicarb 23 type.
So basically,
albumin
seems to be okay, right? Ventilation, right?
I think it's Turner syndrome.
So he has albumin. Albumin is 27, and his sodium and other salt is okay.
Yeah.
Bilirubin. Who said Noonan? You want to speak up? Whoever, I did not catch his name.
Maybe, yeah, no, maybe because he's boy.
Right. Yes, Noonan. You said Turner, so they were thinking about girl.
Yeah, boy. Yes.
Right. So this is Noonan. Would be what other two investigation you need to know to do is you need to do a chest X-ray and you need to do echo, and so you need to think about the Noonan, and especially when there is a IR white set and especially diamond kind of shaped looking eyebrows and small upturned nose, and most cases with the low set, the ear are low set, and over 90% of the cases have like the ears a little bit backward and rotated with a thick helix. I'm not sure if you know what I mean. And the groove, the philtrum, is deeply grooved and can be seen almost in every cases. And they would have poor tongue control, and they have okay, and a lot of developmental issues and pulmonary valvular stenosis. That's the common in half of the patient. So pulmonary valvular stenosis, that's and they will have webbed-necked, lack of sexual development. They have undescended testes. They have motor delay. They have poor coordination, and they have what else? And they will have a clotting factor, especially with combined coagulation deficiency, right? Good. So slide Tali Salah. Yeah, I think I got the feedback. You guys don't get a lot of cardiac catheterization question. Do I skip that, or you want me to discuss that? Quick feedback. Skip. Okay, next. السؤال التالي صلاح. تمام. So you have 11 years old from Pakistan referred to you with jaundice and pallor. So I want you to focus on this question. He's Pakistan, jaundice and pallor. And Dr. Muhammad Al-Amir, you want to take that? Okay, go for it, buddy.
So this is 11-month-old Pakistani boy, referred with jaundice and pallor.
We cannot hear you, Dr. Muhammad. We cannot hear you. You're very far.
This is 11-month-old Pakistani boy. Can you hear me, Doctor?
Keep going.
11-month-old Pakistani boy referred with jaundice and pallor. His hematological investigation revealed we have low hemoglobin, 4.3 grams. Platelet lower side normal.
So platelets okay, white blood okay, retic is 9, MCV 77 low, the rest is okay, no basophilic sibling. I heard on the I heard AHA, which is I think autoimmune hemolytic anemia. No. So the and I heard a malaria. Possible. Again, there is no history of except the visit to Pakistan. But again, I cannot assume this Salmonella typhi possible. But what if I told you I've done a blood test and this is his next slide, Salah السلايد التالي. and هذا شو اسمه electrophoresis. What do you guys think? Dr. Muhammad.
So hemoglobin A is 2.6.
Yeah.
And hemoglobin A2 is 2.7. Could be crystal disease.
Okay. So So, Dr. Asrar, talk to me. You got it right.
Yes, doctor. I think this one it is one of kind of beta thalassemia minor or intermediate,
right
not
as
major.
well.
Sorry.
Okay, so I agree with Nada and Asrar. This is beta thal major, beta thalassemia, because you, go ahead. Go ahead.
Yes, doctor. I was just asking, is it major? Because there is A. I was thinking if it is minor or intermediate.
I mean, the A is it's how much is the A? It's nothing, right?
Yeah.
Right. It's so this is a beta thalassemia, right? And so I think there would be beta thalassemia, and now I think the slide التالي Salah, and I think they might test you on. Was that? So I think you need to probably. I'm not sure what's. You guys correct me if I'm wrong. I haven't done the Saudi board. Does somebody want to say something? I hear like a bit of noise. No? So I think you need to be familiar with the hemoglobin electrophoresis. Hemoglobin itself, like when you do the electrophoresis, the different hemoglobin have look different during the electrophoresis. Usually the electrophoresis separate hemoglobin protein based on their charge. The hemoglobin A seems to migrate closest to the positive pole, the anode, due to the normal charge. And the opposite to that is hemoglobin A2 and the C. And the S and F kind of bounce in the middle, right? So when you have a sickle cell, when you have a predominant, when you get a slide التالي Salah, when you get a predominant S, you think about cell. So if you guys look at this one, which one do you think it's sickle cell? Which number? Because you see predominant 4. Yes, I agree with you, Asa. That's kind of sickle cell. What about a beta thalassemia? Which one? Is it 2? 2, you need a predominant F. I think 3 probably. You need a lot of F in the thalassemia, right? And when you have 8, you have A and S. 8, number 8, you have A and S, that could be trait. And the 7 is mainly S and C, so that's sickle cell, like S and C disease, whatever it's called. Anyway, so that you need to be familiarizing yourself. So the slide التالي Salah. You need to be you need to know what's the normal electrophoresis looks like. The normal, you're gonna see a bit of hemoglobin, a tiny bit of hemoglobin AT, a lot of hemoglobin A, and tiny bit of F. The beta thalassemia is the opposite. You're gonna see the trait soul. You're gonna see a bit of more of A2, less of the A, and a little bit of the F. The thalassemia major is the F is the majority, and the sickle cell anemia, you're gonna the C or the C depends on the type, whether S or C. You're gonna see either C or the S is the bigger one, and the trait kind of still in the middle. Slide التالي Salah. Right. Any taker? What's the diagnosis here? So this is the one that we saw previously. That's called the I think it's called alkaline gel electrophoresis. This one is a different method of electrophoresis called HPL, which is kind of high performance liquid chromatography way of looking at the hemoglobin electrophoresis. Any taker for this one? What is that? even if you don't know how to read HPL or read electrophoresis, Asala, what is that?
Maybe it's normal because the A is normal range and the A2 is normal range, but no, if
Excellent. So what is that?
alpha thalassemia.
That's a normal hemoglobin electrophoresis, right? So when you have thalassemia major, the sickle cell, you're going to see, as we said, hemoglobin S. The trait, you're going to, A and S, the thalassemia major is mostly 90% hemoglobin F, 10% of hemoglobin A2. And the minor is kind of, A2 is increased and the F is about 20%, is a bit more or less than the major. Slide Tali Salah. What about this, Asala?
This having hemoglobin S and there is hemoglobin A. So this is going with sickle trait.
Okay.
And the A2 2.9. So can be beta thalas sickle trait.
Right, I agree with you. Sickle cell, right?
Mm-hmm.
I agree with you. Okay. Slide Tali Salah. So shifting gear to a different beast. Asala, you want to take that?
Okay, doctor.
Give it a try. It's challenging, but give it a try.
Okay, sure. These are the result of ITT, TRH, LHRH in the short of 12 years old boy. And this is the result for glucose, cortisol, growth hormone, thyroid, TSH, FSH, and LH.
Right. So what would be what's going on? So let's go through before we answer the question. What is exactly that? So there is I'm just going to help you there. So there is, when you give the insulin, there's insulin tolerance test, and there's the TRH stimulation test and the LHRH stimulation test. This is in a setting of growth hormone. Yes, the growth hormone stimulation test, Al-Anud said. So when you give the insulin tolerance test, shows when you given the insulin tolerance test, the ITT, what happened with the insulin? You can see a nice cortisol response, right? The 0, and you can see a nice response to the cortisol. That means indicate the adrenal axis is working properly. But when you give the growth hormone, response is quite optimal and delayed. That could be suggesting a growth hormone deficiency. When you look at the TSH response is exaggerated when from the 2 to 13, that could suggest hypothyroidism or maybe a delayed TSH feedback. When you look at the FSH and LH response to LHR stimulation is normal, that suggests the gonadotropin axis is functioning properly for age, right? So that is suggestive of partial growth hormone insufficiency. And the reason I say partial, because the normal response for growth hormone stimulation test should be more than 15 to 20, depending on the assay. So when you have the growth hormone, it's not reaching more than 15. So this is around kind of 8 around 20 minutes and 7 at 30 minutes, and it dropped way below later to 4 and 90 minutes. So when you have a partial response less than 7, this is a growth hormone deficiency, right? So the question, that's the diagnosis, growth hormone deficiency. What would be the next step? You want to make sure that the sella torsica is normal. You want to make sure that there is no craniopharyngioma or tumor or whatever. You want to do the MRI brain, right? And of the pituitary gland, right? And also suggest underlying causes. Again, as we said, that could be hypothalamic or pituitary dysfunction, whether it's a pituitary adenoma or a craniopharyngioma, or it could be just constitutional growth delay. Although this is a common cause for short stature, it would need to be differentiated from the pathological causes by clinical context and a further evaluation. So the summary, the main concern in this scenario is trying to test you how to read the growth stimulation test and whether you can appreciate this is a growth hormone deficiency or not, and what would be the next step would be brain imaging to look at the sella torsica and pituitary gland, right? السؤال التالي صلاح. هسه عاد بدينا الشغلات الدسمة شوي. Any taker for this question? دكتور محمد. دكتور محمد تفضل. دكتور العنود. أسرار. نعم. Manal, anyone?
I will check.
Yes.
Yeah, go for it.
Okay. This is a lung function.
أيوة.
تفضلي دكتورة.
These are the lung functions of a child having difficulty in breathing. So this is the function test اللي هو spirometry result. It gives for me I think this is a restrictive lung disease because no change in measurement before predicted and measured. It's 2%. I think it should be more than 12.
Mm-hmm. So this is restrictive.
If VC is less than 80, which is abnormal.
Okay.
If EV1 normal. If EV on ratio is 2, which is abnormal. Low, I mean. I think it's going with the restrictive lung disease.
Right, but if you look at the FEV1, FEVC ratio, is it normal or low?
Low, it's low.
It's actually normal. I agree with Asala, it's normal. It's 90% of the the measured, the predicted is 90, the measured is 92, right?
Yes.
Don't confuse with the percentile. So the measured is 92, right?
Yes.
Right. So this is normal. And the only time you get a normal FEV1, FEVC ratio when you have low FEV1 and low FEVC, so the ratio stays normal. And that's the only thing you get that when you have a restrictive lung disease. And I agree with you. And this restrictive lung disease could be inherent to the lung, like pulmonary fibrosis, or in the wall, like chest wall deformity or scoliosis, or maybe in the muscle, like in neuromuscular disorder, lung disease. Okay, so that's the likely cause, or maybe causes like CF. I agree with you, Dina. Oh, actually, no, I take it back, Dina. CF is mostly obstructive. Okay, so slide التالي صلاح. So the take-home message from this slide is you need to be familiar with your pulmonary function test. So you can see that FEVC, the vital capacity, FEV1, FEVC, and the FEF at 25-75%. By the way, the last one is measure of the small airway capacity and compliance. They are all of them low. Except the ratio, because in the restrictive, both of them low, and that's why it becomes normal or slightly high. Or in the obstructive is the opposite. Usually the FEV1 is quite low, and the capacity is kind of stays normal and maybe slightly enlarged. That's why you have a low ratio, right? Next. And obstructive lung disease, you may think about bronchiolitis, asthma, bronchiectasis, and cystic fibrosis, and restrictive lung disease, as we said earlier. Slide التالي صلاح. So this is you need to be familiar with the is called the flow volume loop. This is a flow volume loop. You can see on the x-axis, which is the volume loop, represents the volume of the air exhaled or inhaled from the lung. The top one is exhaled, the bottom one is inhaled. That's the x-axis. The y-axis is mostly on the flow in the liter per second. So you can see the peak expiratory flow and the FEV1, the FEVC measurement there. So you need to be familiar yourself with the flow volume loop, right? Slide التالي Salah. And again, so when you have a you look at this one, for example, the first one is the top left of the slide. This is a normal spirometry graph. In the flow peaking quickly before the gradual decline, and this is indicating of efficient lung function where the air can be expected swiftly and fully. In contrast, the middle one, which is you have a bit of a plateau, and the plateauing it's just not reaching the in the flow curve. It's not reaching. I cannot point. It's very hard. So you can see the green line is not reaching the horizontal normal peak line quickly. It's taking a bit of a gradual slope to reach it, and that is reflective on the flow volume curve is as a concavity. It's called coving because there is a mildly decreased peak expiratory flow. Is not flowing as quick as possible. That's why leading the coving. So when you see that in the exam, you say this is obstructive pattern. But if you have everything identical to the normal, but everything is small, you think this is a restrictive pattern, right? So that's you might get tested on these, showed one of these images and say, what is that, right? And slide Tali Salah. And that's another one, same thing. I think the same idea. The top one is normal, the middle is kind of obstructive. I want you to pay attention to the right middle, the one that looks like مثل البيضة, egg. This is commonly tested kind of when you have a fixed airway obstructions, especially with the vocal cord dysfunction or vocal cord dysfunction. And then they give you a scenario of a teenage girls, especially girls, and she's athletes, and she start running and have exercise, and suddenly has a choking episodes, and she cannot breathe, and that's called focal cord paralysis or focal cord dysfunction. And you do the pulmonary function test. Of course, you mimic the exercise. Either you tell them to exercise, or they give them certain inhaled material. I forgot what it is, whether it's a 3% saline or salt, whatever. And they try to mimic the exercise, and they do the curve, and it becomes like this. And this is a diagnostic of the vocal cord paralysis. And the rest is for you. Next, slide, Tali Salah. Oof, that was quite a marathon. Okay, next. Who's going to take that? Anyone? دكتورة العنود؟
Yes, doctor.
يلا تفضلي دكتورة.
A baby born 26 weeks of gestation was ventilated from the age of 2 minutes and course of given for HMD. On day 3, the ventilator setting were as follow: a rate 50 per minute, IT 0.45, the BIB over B 18/4, والFiO2 35%. C blood gas, pH 7.34, CO2 5.6, oxygen 6.2, والبase deficit minus 3.4, MAP 32, without any troop support. 4 hours later, following the last gas, the oxygen requirement increased to 70%, and the baby became bradycardic, and arterial blood gas was taken at this time and showed the following: pH 7.21, CO2 8.8, oxygen 3.06, and base deficit minus 9.
So what's going on? What happened, Al-Anud?
There is respiratory acidosis with increase with oxygen requirement and bradycardia.
So
Maybe have to, could be RDS or pneumothorax.
I agree with you. Pneumothorax. This is a sudden changes, right? So so that's a sudden changes. He was okay, stable, and suddenly dropped. So that would be a okay. How do I refuse this call? Whatever. Can you still hear me?
Yes.
Right. And so that's a pneumothorax. What would be the next bedside test you do? Bedside test.
I would like to auscultate and seeing to listen where is the decrease of air entry, then needle.
Right. And I would do a transillumination test, transillumination, like Abdullah said. And what's the gas is showing you? You said respiratory acidosis, and what would be the ultimate treatment is insert chest to drain initially for this tension pneumothorax, which is needle insertion to relieve the pressure, and eventually you need the chest tube. I agree with you. Okay, slide تالي صلاح. دكتور عبد الله يتيمي تفضل. اوكي تفضل دكتور عبد الله. دكتورة منال، دكتور عبد الله، اي واحد تفضلوا. This is a slide trying to test you if you appreciate the genetic tree, the family tree. Okay.
This is the family tree of family with inherited disorders and mutation in gene located on chromosome 7. Further,
so what is the mode of inheritance?
This is autosomal recessive inheritance.
Why would you say so? I agree with you. Because this is autosomal recessive, yes.
Because both the parents are carrier.
Exactly. And what is the chance of affected child?
It is 25%.
Excellent. What is the chance of a normal child?
25%.
What is the chance of having carrier child?
50%.
Excellent. 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 Okay. And okay, that's about it. I think that's the drive home message from this slide. They might ask you, give me a example for autosomal recessive. So have something in mind, okay? Slide تالي صلاح. What about this one? دكتورة منال, دكتور العنود, أسرار, محمد, عبد الله.
Autosomal dominant.
لا, this is mitochondrial disorder. Mitochondrial.
Okay, who said mitochondrial?
Manal, أنا.
Dr. Manal, explain to me at your colleagues why it's mitochondrial.
Because
actually, hold on a second, Manal. You spoke a lot. Thank you for your effort. Nada, you're raising your hand. Go ahead, Nada. Thanks, Manal, for your effort. You're doing really well. Fantastic. I'm proud of you. Nada. Are you going to speak up, Nada, or no? If no, then Manal, take it. Oh, Nada says I don't have mic. Go for it, Manal.
Okay, this is mitochondrial.
Why is mitochondrial?
Because always my mother is spread the disease while the
Exactly.
Yeah.
I'm
Why
really
the
proud
boy?
of you. You see, the mom, when is affected, it's passing to the
the whole kids يعني
all kids. When the
yeah.
dad is affected, is not passing it down. So this is a mitochondrial inheritance. Mitochondrial inheritance is the mom issue, right? Excellent. Good for you. Slide تالي صلاح. Okay. So I think this is for you. Autosomal dominant, it doesn't skip generation. Autosomal recessive, skip generation. X-linked is usually the mom moving it to the kids, and the dad doesn't because it comes from the mom. The same thing for X-linked. The mitochondria is the mom's always passing to the kids as well. Next slide, Salah. Slide Tali, Salah. Okay, that's the same thing. It's basically nothing different about mitochondrial disease. The slide Tali. Okay, so this is a karyotype. I mean, I'm giving you the answer because I'm putting the circle. Can anybody take it?
This is trisomy 21 Down syndrome.
Trisomy 21. So basically, the take-home message from this slide, you need to be familiar looking at karyotyping, okay? Look at the chromosome 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 18, 19, 20, 21, and 22. 22 chromosome autosomal, all right? And you have the X and Y, right? Or the X and X. Slide Tali Salah. Okay, what is this one? Can somebody, mom brought you to the clinic, this report, and say, doctor, they gave me this from Riyadh. I don't know. They did not explain to me. They did not do counseling. And she asked me for counseling. What is that? Okay, Asrar, Asala, one of you guys.
Yes, doctor. I see this is a karyotype sheet with results written as a 47XX plus 21, which goes with Down syndrome.
Right. So there is 47XX and there is 46XX. So what is that?
Extra chromosome.
Right. So the problem is where? What is that called? Sarah, talk to me, Sarah.
Yes, doctor.
Yes, go for it.
Since there is a different type of cells like 47XX and 46XX, it goes like with the mosaicism or mosaic pattern.
Mosaic trisomy 21. This is mosaic Down syndrome. Okay, you got to be careful. Excellent. Good for you. If they gave you only 46XX and with extra copy in the 21 chromosome alone, this is trisomy 21. If they gave you another slash, that mean they analyze other cell and there is a 46XX. They analyze 6 cells that has this 46XX and they analyze 15 cells that has 46XX plus extra copy in the 21. So that's a mosaic, mosaic Down syndrome. Next, Salah, slide Tali. Okay. Nada, go for it. Asala, Al-Anud, Asrar, Muhammad, Abdullah.
Okay, doctor, I will read it. This is an ataxic 3 years old girl seen in pediatric neurology clinic. The blood film is normal. MRI generalized brain atrophy, normal amino acid, alpha feta protein normal, lactate normal, CSF lactate 1.2, the very long chain fatty acid normal, neuroconductive and EMG normal. The urinary VMA is high. So most likely it's going with neuroblastoma, maybe.
What do you think?
I'm not sure صراحة.
So you have a MRI. MRI is generalized brain atrophy. So generalized brain atrophy. And you have amino acid and organic acid is normal, so that's against homocystinuria. You have alpha fetoprotein that is with a normal limit. Although I would have told you usually later in life they will have high alpha fetoprotein. The CSF lactate, plasma lactate is normal. VELCAD is normal, which is against the Zellwegers and whatnot. And nerve conductions and normal. And you have high VMA, right? And the child is ataxic. So this is a scenario for what? So this is ataxia telangiectasia. This is ataxia telangiectasia, and they will have risk of neuroendocrine tumors, so they will have a VMA. This is a trick question. This is not a neuroblastoma. Neuroblastoma, they will have normal brain. This is a generalized brain atrophy. So this is 3 years. So this is ataxia telangiectasia, right? So the other physical finding they ask you, say telangiectasia in the ear, in the face, and the eyes. What do you look in the eyes? You look for nystagmus. How would you test them? You do immunoglobulins. You look for the hyper IgM, like high IgM. And you do a DNA breakage studies, and you do abdominal ultrasound for a hepatoblastoma. The slide tally, Salah. سلايد تمام انت نقلت اصلا. Okay, so this is this is X-linked AGAM. Okay, so you have 2-year-old ulcerated skin lesions, no lymph nodes noted, and has a frequent otitis media. He's failing to thrive, blood culture Pseudomonas, and you look at his immunoglobulins, all are low. This is AGAM. Okay. Slide tali, Salah. Okay, any taker for this? A child can build Tower of 8. This is what he can copy. What is his age?
4 years.
4 years. Why 4 years? Why it's 4 years? And Gina, why is it 3 years?
Yes, Doctor, he is able to draw a square, cross, and circle by 3 years, across 3 to 4, and the square by 4 years.
Right. So I agree with you. That's kind of more sitting, although the right answer in the textbook here, it says 3 years, but I agree with you, square is 4 years. So I would say 3 to 4 years. Okay. Okay. Slide tali, Salah. Skip slide tali, Salah. We said we don't do cath. Slide tali. Okay, any taker for this question? You have 1-year-old boy with a failure to thrive. His birth was 4 and has been breastfed for 6 months. At the age of 1 year of age, his weight is 8 kilo. White blood cell normal, and hemoglobin is normal, platelets okay-ish. Blood film has hypochromia, anisocytosis, and acanthocytosis. X-ray of the wrist shows evidence of ricket. Serum cholesterol is low, and stool shows fat. Globules. Manal, what do you think?
I think this cystic fibrosis case.
Right. So let's cystic fibrosis. Okay. I did not give you the history he had. He's 1 year. At least admitted to hospital for repeated chest infection. So I did not give you that. I gave you only fair to thrive. So what's the issue? Fair to thrive. He's not absorbing fat. He's having fat globules. And he has rickets, which is basically fat soluble vitamins not getting absorbed like vitamin D.
Yep.
And the buzzword, the blood film has acanthocytosis. This is the word acanthocytosis is something. So this is a scenario of A-beta lipoproteinemia. A-beta lipoproteinemia. They present with the fat malabsorption, and it's you diagnose them with you do a lipid. The next step would be a lipid profile. It's a genetic. It's a autosomal recessive disorder resulting from the lack of synthesis of apoprotein B, which is essential for the formation of the LDL and the very low density lipoprotein and the chylomicron. That's why you have the cholesterol level is very low, less than 1.3, and triglycerides very low. And they have diarrhea, fat malabsorption, bleeding due to vitamin K malabsorption as well. And the buzzword is acanthocytosis, basically spiky red cell. Spiky red cell, acanthosis. Acanthocytosis is always present from birth, but is not pathognomonic for it, okay? So that's what it is. You support them with protein, you support them with ADEC and basically frequent follow-up. What are they are risk of? They are risk of ataxia and retinitis pigmentosa. Ataxia and retinitis pigmentosa, right? They usually, ataxia and retinitis pigmentosa, they appear at the end of the first decade after 10 years, and they're usually progressive. They have a profound neurological features issues, like basically to vitamin E deficiency, right? And they usually die from a cardiac arrhythmia. You treat them with vitamin E to prevent the development or progression of eye and nervous system. And you also support them with vitamin K and A and D, and low-fat diet is also recommended, and you give them MCT oil, okay? Next. Okay, anyone? صلاح can you صلاح ممكن تجي الغرفة الله يرضى عليك. Anyone take this question? Come on, guys. I'm already 50 slides and I have 92 slides. So.
Okay, I can read it.
Okay.
This is a 7-year-old child present with the status of epilepticus. The seizure terminate with emergency department. These are the investigations result. Of note in the past is a history of pica. Hemoglobin is low. Total white blood cells is normal. Platelet normal. Calcium maybe a little bit high or normal. Glucose normal. Sodium low. Potassium normal. CSF no organism. I think RBCs with white blood cells. There is high white blood cells. It should be 0, I think. Protein is normal, maybe.
Right. I mean, if you correct the white blood cell to the RBC, I think
it would
that
be normal.
Because that's a traumatic step, right?
Yes.
Amino acid is positive, the protein is positive in the urine. So basically, he is dumping Basically, he's having a proximal nephropathy, but it's like a Fanconi-like picture. That's why he's dumping the protein. And so there's something happening that's connect status epilepticus, connect pica, connect low sodium, and connect Fanconi-like proximal nephropathy. What would that be? Dina, what did you say? You got it right, Dina. Speak up.
Could be lead poisoning.
Lead poisoning.
Yeah.
Lead. So it's not lead poisoning.
Yeah.
Lead someone. It's lead poisoning.
Yes.
Because I hear a lot of my Saudi colleagues say lead poisoning. It's lead poisoning. Okay, so it's lead poisoning. The next step would be so this is a lead encephalopathy scenario. Okay, so the test they wanna appreciate when you have a child with pica and anemia. So you have pica, anemia, status epilepticus, and I have a protein in the urine. This is a lead nephropathy, lead encephalopathy picture. You want to do serum blood level. You want to do long bone and abdominal X-ray looking for the lead deposit. Okay. So, slide التالي صلاح. Okay. Dina. تفضل دينا.
Okay, 6-month-old infant is referred with failure to thrive. He has been constipated since birth. His milk intake is 120 ml every 2 hours. He woke during the night crying, but he will go back to sleep after feed of 120 ml of milk. Sodium is 131. الهيموجلوبين 12 البوتاسيوم 2.7 كلورايد 8.5 البلاتلت 190 الكرياتينين 45 البروتين 30 اليورين في الصوديوم 10 والبوتاسيوم 60 البي اتش 7.50 والبايكارب 30.
So what's going on? Can you analyze it for me?
This patient could be in constipation since birth, could be Hirschsprung disease.
So, okay, so that's Hirschsprung would explain your, guys, you're posting things I cannot see because I'm looking at the screen and speaking from the phone. So if you have any thoughts, just feel free to speak up. So Hirschsprung can explain, Sheikha, you want to talk to me, Sheikha? No?
هلا دكتور. This is 6 months old, hyponatremic, hypokalemic, metabolic alkalosis. So most likely goes with pyloric stenosis.
Okay, so this is hyponatremic,
hypochloremic, metabolic alkalosis.
Hyponatremic,
hypokalemic, hypochloremic.
Let's see, hyponatremic, hypochloremic, hypokalemic, hyponatremic, hyper. So it has to be hypernatremic, hyperkalemic, hypochloremic, metabolic alkalosis. So that this scenario does not fit. Okay. So the only thing can explain low sodium and low potassium and low chloride in a setting of a kid is waking up during the nights and probably want to ask for milk and a drink that much and go to sleep. That's a scenario of a not cow's milk protein allergy. That could be a DI scenario, whether it's a nephrogenic DI or central DI, or could be psychogenic polydipsia, right? So especially when you have a lot of dumping of potassium in the urine. Slide tally. Okay. You have 10-year-old brought to the emergency department by her mother. She developed worsening and swelling around her face and eyes, around the eyes and the ankle during the afternoon. Her father died suddenly from upper respiratory tract obstructions of uncertain etiology 10 years ago. You look at her urine, normal, no protein. Her hemoglobin, her CBC seems to be okay. Her electrolyte seems to be okay. Her liver enzymes, billet, okay. Protein is okay. IgE is high, C3, C4 normal. What is that? Anyone? Quick. No. So that is with the setting of family history of sudden death. I mean, you could argue this is anaphylaxis, but what they're getting at, especially with the giving you C3, C4, that's angioedema. I agree with you, Asrar. This is familiar hereditary angioedema, and you would test it with the, what's the investigation of test? Investigation of choice. Well, somebody says C4, Al-Anud said C1. I agree with you, Al-Anud. This is C1 esterase inhibitor deficiency assay, and you refer them to allergy immunology for further workup, probably for hydrocortisone, for antihistamine, and further follow-up, because the risk certain tests. So probably danazol is the treatment of choice. The reason for that is usually because it raises the C1 esterase inhibitor level, and to prevent the attack. The contraceptive preparation may help in girls, especially in the post-pubertal period. So the problem is in the there is a C1 esterase inhibitor deficiency. That's the problem. That's why danazol is gonna raise those. Okay, slide Tali Salah. Okay, so you have a child that is presenting to you with, she's 2 months, presenting with a lot of lethargy, irritability, and he's been expressed normally. He received a mix of fruit juices on the day of the admission. So that's kind of classical scenario. 2 months fed juices, fruit juices, whatever. I mean, it's too early to feed him, but mom fed him. When she went staying with a friend, they gave him this. He started vomiting, and he became acidotic. He was sick, and the lactate is high. It's basically shock, like kind of picture. And he started dumping glucose, amino acid, proteinuria, and oh, by the way, you did the test. Excellent. Asrar, talk to me.
Yes, doctor. I think this patient, as he's having hypoglycemia after he drank juice, it's most likely because of fructose intolerance.
Right. So this is a primary unborn error of metabolism. It's called the fructose intolerance. It could be fructose intolerance, and it could be either a fructose 1,6-diphosphatase deficiency or fructose 1-phosphate aldolase deficiency. This child needs a GI consult and metabolic consult, and she eventually would need a liver biopsy, right? Next is slide Tali Salah.
دكتور نوقف هنا أو ناخذ سلايد؟ إنه باقي 4 دقائق على الساعة 10 بالضبط.
والله بكيفكم.
على راحتك دكتور.
على راحتكم أنتم، يعني نوقف. أنا باقي لي أنا وصلت 53 هسه. باقي لي صلاح إذا تمشينا بالسلايدات، بس خلينا نشوف الانترستينج سلايد. بس مشينا بس لحظة. لا مو هيك، لا على كيفك، شوي سريع أنت كلش. صلاح ارجع للسلايد الأول اللي احنا كنا واقفين يمه، ومشيني واحد واحد، يعني أنت بعيد يمي. ورا لحظة.
Okay, this is a scenario of galactosemia. Okay, ورا واحد شوي شوي. This is obstructive. Okay, let's take that. Anyone? راح نمشي selective. نمشي ونchoose. Anyone? Okay, Manal, talk to me.
11-year-old girl is seen in the chest clinic with a history of chronic cough and poor growth development. Lung function tests are performed. FVC, there is pre and post bronchodilator. So post is more is high. FEV pre and post is high, more increase. I mean, so ratio is pre 87 and post 95. It's going with obstructive lung disease. I think most likely cystic fibrosis due to poor growth development and chronic cough.
I agree with you. This is a obstructive lung disease due to cystic fibrosis. The test you need to do a sweat chloride, blah 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 blah, and could be PCD as well, primary ciliary dyskinesia. So you need to do some sort of bronchoscopy and biliary, what? Yeah. Slide تالي صلاح. سلايد تالي. هذا fasting lipid profile familial hypercholesteremia. سلايد تالي. Okay, I think that's interesting. Manal.
This 4-year-old boy is referred. He can walk but no run. He often trip over. He can copy a circle, cross and square. He knows 6 colors and occasionally speaks 3-word sentences. He can understand game rules and share them with others. What is the differential diagnosis?
Okay.
He 4-year-old. I think he between
he trips over, he falls.
This is gross motor delay, maybe the chain.
Yeah, that could be myopathy, could be cerebral palsy. What is his gross motor developmental age?
Delay. Gross, I think 12 months maybe, or 18 months.
I agree with you. He's 12 to 15 months. What would be the Lister 3 investigation you would do? If you would think this could be Duchenne, he's a boy.
Okay.
So you would do a CK, you do EMG, you do brain and muscle MRI, and basically, okay. Next.
What? Okay, go.
Yeah. صراحة السلايد التالي. بس لحظة خلي أشوف. Okay, so that's hemophilia A and B. Okay, slide تالي. احنا تكلمنا على ال bleeding tendency. Slide تالي. Okay. This is okay. I think that's whoever who wants to take this one. I think that's another domain. I think you might get tested on it. So 5-year-old admitted with the history of drowsiness and unsteady gait, suffered from generalized tonic-clonic seizures at home. She has a similar episode at the age of 8 months and 16 months. Her siblings died at the age of 6 months with the progressive seizure disorder and failure to thrive. Progressive. Investigation, sodium is okay, potassium is okay, bio and creatinine and glucose okay, lactate is okay-ish. LFT is normal. Ammonia is quite high. Ketone is low. CSF okay-ish. And you've done EEG. There is a spike and slow waves. So that what's going on?
I have ammonia, and oh, by the way, I told you there is no acidosis, but by the way, there is a alkalosis. Just to make it easy for you, what is that? What is that? So that's a urea cycle defect. Okay, so you need to when you have a ammonia, you have a progressive neuropathy, you have seizures, and you have a family history of similar, and you have a high ammonia, and you have a alkalosis. Think of urea cycle defect. Okay. Slide Tali Salah. So basically, when you have high ammonia, think about it. Do I have ketone? No, I don't have ketone. If I don't have ketone, think about the urea cycle defect, which is a primary hyperammonemia, whether it's ornithine, whether it's the CPS or the arginase or the ASL or the SS, and that's the test. If you have positive ketoacidosis, think about the organic aciduria. So that's basically the summary for hyperammonemia. Slide Tali Salah. Slide Tali. So that's not important. Slide Tali. Slide Tali. Okay, so we talked about the dumbbell. What of the dumbbell that could be the reason for this girl? And what's the gas is showing? Just go for the what is it? Anyone? Okay, so that's a scenario. 11-year-old found to be comatose, sweating profusely. Her mother suffered from heart attack 1 year ago. Her blood gases, you look at the urine. Okay. Sodium is low, potassium is low, and the albumin is low, urine reducing substance. So what could be? What's going on here? Anyone? The pH is low with normal PO2 and a slightly low PCO2. What does that mean? So you have a metabolic acidosis with mild respiratory alkalosis, right? So not sure. Yes, that's exactly it. Whoever said Asala, talk to me.
Yes, hi, doctor. So
Right.
most likely with this age, and the mother was taking medication for this heart attack and metabolic acidosis with respiratory alkalosis, going with aspirin.
Excellent. This is a salicylate poisoning, especially when you have low pH and you have normal PO2 and a slightly low PCO2 because it's hyperventilating. At the same time, you have metabolic acidosis and mild respiratory alkalosis. This is a aspirin ingestions. Okay. Slide Tali Salah. Okay. Slide Tali. Slide Tali. Okay, so 2.5-year-old has a normal motor developmental skill. He seems to be very shy. He plays alone, has no eye contact with the others in the room. He has minimum understanding of verbal words. He can say more than 10 single words. Okay, so that's autism. What is the age of his language development? Manal, what's the age of his
Doctor, 1 year.
Excellent. 15 to 18 months, kind of, because he's saying more than 10 single words, no sentence. Probably more than 1 year, 15 months, probably. Excellent. Excellent. Okay. Slide Tali Salah. So what's the difference? What is this type of milk? I think that's hard. The mother is feeding this milk, and they ask you what's the type of this milk. This is likely cow's milk. What's the difference between cow's milk, this milk, and the breast milk? This milk has high protein, high calcium, and high phosphate compared to the mom milk. If they ask you that, I really doubt it. Okay, next. Salah, slide الثاني. تالي. تالي. اللي ورا. اللي ورا يا صلاح. تالي. التالي. Okay, 9-year-old present with the history of progressive loss of vision, painful eye, and she has an area of numbness on her face. Endoscopy, fundoscopy revealed bilateral papilledema. She becomes ataxic, and her MRI shows area of demyelination in both cerebral hemisphere. What's her diagnosis? Right. I mean, ADEM, and also especially with the area of demyelination and become ataxic and bilateral papilledema and numbness in the face and a progressive loss of vision and painful eye, I would go with the multiple sclerosis more than ADEM. And I would send the CSF for oligoclonal bands, and I will do MRI spine. I will do visual evoked potential, and as well as probably consult my neurology to start a steroid. Slide Tali Salah. Okay, I have this 7-month-old presenting with the continuous seizure and required ventilation. He looks dysmorphic. He has a sparse, kinky hair, and he has low set ear, and he has VUR on the mega scan, MCG scan, which is VCUG scan. Just no reading, no further. And MRI, yeah, so Menkes syndrome. This is Menkes syndrome. You need to do molecular genetic study, and you do a hair for microscopic study. What is Menkes? Menkes is X-linked recessive. It's opposite to the Wilson. It's basically the problem in the copper deficiency, right? Okay, so it's Menkes syndrome. Okay, slide Tali. Again, this is a scenario of another mitochondrial disorder, because you have myoclonic jerk controlled by clozapam. You have global developmental delay. Parents are consanguineous. You look at the ammonia seems to be normal. The lactate seems to be slightly high. The rest of the workup, the brain MRI, yes, that's MELAS. Manal, tell us what's MELAS. And you have brain atrophy. Okay, MELAS. What's MELAS?
MELAS is mitochondrial encephalopathy, lactic acidosis, stroke-like events.
You have the lactate slightly high as well. I agree with you. Proud of you. Very good. Mashallah alayk. Mitochondrial disorder, you need to send white cell enzymes, and you need to do skin biopsy for tissue fibroblast. This is MELAS, okay? And especially the lactate and pyruvate from the blood is very high, and you do the lactate pyruvate ratio is usually more than 50-1, suggests the metabolic block in the respiratory chain. Okay, so slide Tali Salah. 10-year-old present with vomiting, lethargy, and they are a brain, no abnormalities, and the VELCAD is normal, amino acid normal, ammonia is quite high, okay, so pH, there is acidosis. Okay, so that's organic acidemia. I agree with you. Okay, good. Because there's acidosis and ammonia, so this is organic acidemia as we agreed earlier, right? And I would like to see if there's any ketone or not, but that's fine. Okay, next. Slide, Tali Salah. Similar or metabolic, this is a 6-year-old seizures, happened twice in the morning, lasted for 2 minutes. You look at his lactate, okay, glucose is low, carnitine is high, and what is this? Yes, fatty oxidation defect, and you send it for with the very long chain fatty acid profile, and you do for acylcarnitine as well. Slide, Tali Salah. Three-month-old history presenting with, this is all metabolic. We're trying to beat up metabolic. So you look at this lethargy, jitteriness, not feeling well. He has the only abnormal, you look abnormal high alanine, low phenylalanine, and taurine. So that's phenylketonuria. Okay, so that's the scenario of phenylketonuria, and you have the rest of the workup. Slide, Thani Salah. Okay, Ilwara. Anyone can take this one. This one is interesting. خلصنا وصلنا تقريبا 78 على وشك الانتهاء. Anyone?
I will read it, Doctor.
Okay.
This is 5-week-old
I will
boy.
read it. Give me your impression, okay?
Okay.
5-year-old boy present with a history of vomiting with his mother says he can reach to the other of. Okay. What is weak? Manal, what is weak?
5 week and good 5 year.
Oh, 5 weeks, sorry. I thought that's a diagnosis. Okay. So the pH is alkalotic, right? And the rest of the workup seems to be okay. Oh, and I told you he has hypochloremic metabolic alkalosis. And he has a project.
This is
That's a
pyloric stenosis.
I agree with you, Manal. Thank you. Nada, I agree with you. So that's a pyloric stenosis, need pyloromyotomy. Okay, slide, Tali Salah. Okay, so that's a 25 years old present with jaundice, non-consanguineous. You look at the jaundice, the IPTT is prolonged, INR prolonged, so that's a biliary atresia. Excellent, thanks, Asrar. You need to do a Kasai procedure. Next, slide, Stan Salah, Wara. 13-year-old present with joint pain, swelling, mild fever up to 38. He has anemia. He has a ANA positive, double-stranded negative, and he has joint pain. So that's a juvenile arthritis. Okay, consult rheumatology. Yeah, JIA or juvenile rheumatoid or juvenile idiopathic, whatever you want to call it. Slide, Tali Salah. This is a scenario of anemia of prematurity. You need to be comfortable with it. Slide, Tali. Okay, so that's a 10-year-old present with lethargy, no feeding. So basically have high 17 OH. So that's, yeah, CAH. Perfect. Congenital adrenal hyperplasia. Slide tally. That's interesting. Whoever want to take that, that's a nice one. Okay, what is that? A 15-year-old presented with the sparse pubic hair. What is the clinical problem? So she had a precocious puberty, secondary to CAH. Okay, good. What do you need to do? You need to do a ultrasound. Slide التالي. الورا. That's a growth hormone deficiency. You need to do a stimulation test. الورا. That's a congenital, that's a hypothyroidism. Okay, الورا. So they come in clusters. So we gone over all the rest. We gone over the cardiac, hematology, now metabolic, now genetic. Now we're done the endocrine, right? Okay, so what is this? Floppy baby, 3 months, reflux is absent, upper and lower limb, and you do head and brain MRI and increase the spinal and the lumbar region. So that's a transverse encephalomyelitis, right? Or maybe it could be botulism, but botulism doesn't give you the increased signal in the lumbar region. So that's a transverse encephalomyelitis, whatever the reason is. You need to consult your neurology. Okay, slide Tani. Okay, so you have, this is a proximal weakness. You have CK, so this is myopathy again. Slide Tali. Liwara. So that's the scenario of aseptic meningitis. Because he has focal seizures, he starts being unwell, lethargic, having focal seizures, and you do a CSF, you see RBC there, and you see the gram stay negative, and you see EEG showing wave activities, and show wave activity, but no focal discharge. This is a septic meningitis. You need to rule out HSV, so sent for CSF PCR, right? Slide tally. Yeah, so that's interesting one, just before the end. 7-year-old present with the history of ataxia, dysarthria. She's ataxic, she's dysarthric, she is dysphonia, she cannot talk normally. When you talk to her, she's like, she has hot potato in her mouth, like, it's like a nasal speech, right? She cannot swallow. If she swallows, the food comes from her nose, right? She has poor tone and poor reflexes and upper limb, power and tone and reflex in her upper and lower limbs entire normal. CSF shows no abnormality. PCR for HSV is negative. What is that? What is this? What is it? Come on. ADEM, myasthenia. Okay. Botulism. I'm asking you the problem, the description of the problem, not the diagnosis. So this is bulbar palsy. Bulbar palsy, the only thing you can differentiate between bulbar palsy and pseudobulbar. Bulbar is a lower motor neuron lesion. Pseudobulbar is upper motor neuron lesion. They present exactly the same. The only difference that the pseudobulbar usually has a exaggerated reflexes, where the bulbar is depressed reflexes. And basically basically also the pseudobulbar usually present with weird emotional out controls called uncontrolled laughing, and they start laughing with no reason uncontrollably, and they start crying without reason uncontrollably, and they're usually stiff and spastic, where the pseudobulbar, the bulbar is more in the lower limb. It's basically like a brain stem stroke or botulism or motor neural lesions like ALS or infection, where the pseudobulbar like stroke, multiple sclerosis, or higher brain injuries. So you need to appreciate the difference between bulbar and pseudobulbar. Okay, final slide, slide al-akhir. And so that's the ADEM you've been waiting for. A lot of you guys been saying a lot of ADEM. So 10-year-old present with abnormal movement in her arms, legs, which looks like spasm occurring if every 10 to 20 minutes. You look at her CSF. Basically, it's everything is normal. The CRP seems to be slightly elevated. You do serum amino acid, urine organic acid seems to be MRI of the brain shows white matter changes. So that's what the ADEM. Okay, excellent. Any question? So basically, this is ADEM. The ADEM usually follow a viral illness or measles immunization sometimes. In some cases, has no you cannot find a cause, right? And it's usually abrupt onset, may consist of loss of consciousness, of seizures. And you do the CSF. The CSF shows a lot of cell pleocytosis and mild increase in the protein. Immunoglobulin oligobanding test should be done to differentiate ADEM from the other demyelinating disease, such as multiple sclerosis. MRI shows increased signal on the T2-weighted images, usually involving the white matter. So that's the trick, is white matter. When you hear the white matter, diffuse involvement, so that's kind of ADEM, okay? Spinal cord lesions are clearly seen and may enhance gadolinium, okay? Treatment usually supportive if the diaphragm is involved and bulbar nerves are involved. Corticosteroid can be given treatment for this condition. Usually with the treatment, more than 70% will recover. I wish you guys all the best. You've been great.
مشكور دكتور محمد، جهد كبير تشكر عليه، يعطيك
الله
العافية.
يرضى الله يعافيك.
الله يعافيك ونفع الله بالتوبة عندك يا دكتور، يعطيك العافية. أي سؤال للدكتور على السريع؟
شباب بنات أي سؤال؟ I take it there's no questions. Okay. You guys have a good night.
Yeah, good night. يعطيكم العافية، شكرا جزيلا.
السلام عليكم.